for coming to our second annual Center for Community and Global Health Symposium. I was just remembering yesterday, our first symposium. It was actually around March, right before everybody went home for COVID. So this has been about a year and a half with COVID. So I know with that time, a lot of our lives have drastically changed. We would have not thought anything like this would have happened last year during our first symposium. We actually talked about vaccinations too, of all things. So there's been a lot of questions. There's been a lot of changes. I know all of our lives have been impacted somehow through COVID. And that's really what this symposium is looking at today. There's a lot of questions about things like, what does the future look like? What are some long-term side effects of COVID? Are there long-term side effects of COVID? And really just how do we get back to a little bit of a normal or an altered normal? So this is what that symposium is going to look like today. One of the biggest advantages of this symposium is that it really looks at multiple sides of that issue. So we have speakers from various backgrounds. We have speakers looking at the health areas. We have looking at exercise, nursing, nutrition. It's really an interdisciplinary approach that we're focusing on this one. And this is really from the faculty in the School of Health Professions. One of the approaches that we take in the School of Health Professions is to have the interdisciplinary approach, the collaboration. So this is really directly from the School of Health Professions faculty work. They've been doing some work for some future grants, and a lot of these discussions have started because of that. So with this presentation today, they will be able to share a lot of what they have been researching and what they've been learning as well. So with this one, I mentioned the School of Health Professions, and this is, so you're not in person if you are online, but the School of Health Professions has been here for a couple years. It was a reorganization of all of our health majors. So if you are around the area anytime in Greenville, South Carolina, we are actually in our new building. It does look gorgeous. The students are here and they've had a really great time this year. But in the School of Health Professions, we do really encourage the focus on collaboration, like I was saying, the focus on innovation, and really just the community engagement. So all of this is really focused on how we can help the community, how we can promote health in all of our areas, and how we can do that here. So we do have a short video clip of introducing the School of Health Professions to you. And then after that is done, I'll come back up and do some general introduction to our speakers. So just wanted to say thank you again for your interest in these topics. And I hope you enjoy the seminars and the sessions that we have today. Before I introduce the next speaker, I just have a couple of housekeeping announcements. So if you do have questions anytime throughout any of the sessions, if you're on Zoom, if you could put those questions in the Zoom chat box. We have one of our students monitoring that, and so he will talk to the speaker and will communicate what those questions are so we can have the answers for you. As well as at the end of the symposium today, we will have a little bit of a Q&A panel time. So if you have a question that you've been wondering and you've not asked it on any of the sessions, or if you have a question for everybody, you can hold that question till the end, and there will be several people who will be doing a panel Q&A towards the end. So right now, I'm going to turn it over to our first speaker. She is in Columbia, South Carolina right now, Dr. Jane Kelly. She is the Assistant State Epidemiologist, and she is going to talk about, from her perspective, what she's seen with COVID and what we can learn from her experiences.
Thank you very much, and thank you again for inviting me to this session. I love the agenda. There are many other talks that look of interest to me. I think you have to, let's see, I'm just bringing up my slides. Hang on just a second. There we go. I'm going to talk to you this morning about the impact on public health in South Carolina of COVID-19, but also to talk a little bit about vaccines, how do vaccines work, and vaccine hesitancy, which is greatly of concern for us. First, I need to back up a little bit and give some just basic biology to make sure that we're all on the same page. These are a number of terms that are sometimes used interchangeably, but really do mean different things. Coronaviruses are a family of viruses. They include some common cold viruses, as well as SARS-CoV-2, the virus that is causing the current pandemic. COVID-19 is the name of the disease that SARS-CoV-2, the virus, causes. And I'm going to pay special attention to a particular protein on this virus, the spike protein. The little cartoon on the right-hand side of the slide shows what the SARS-CoV-2 virus looks like under an electron microscope. There is a squiggly line in the center that represents the RNA, the genetic code of this virus, and it's surrounded by a lipid protein coat that includes a spike protein that sticks out, and it is that spike protein that is key to entry into a cell. It acts almost like a key in a lock to open the door to gain access to the cell. It attaches to the ACE2 receptor on the cell, and it injects the viral RNA. So in this cartoon, it demonstrates that general process. You can see in the upper left-hand corner, there is the SARS-CoV-2 virus. It is attaching to that receptor via the spike protein. That's how it gains entry into the cell. Once in the cell, it hijacks the cellular machinery to create new viral particles and then releases those viral particles to go infect other cells. I'm sure you all by now know the symptoms of COVID-19. Some people are completely asymptomatic, but most people have some symptoms: cough, fever, chills, aching all over. Occasionally we have people with shortness of breath or difficulty breathing, sore throat, or this really strange symptom of a new loss of taste or smell. Unfortunately, some people go on to have systemic symptoms. They basically have vasculitis that is disseminated. You know, anything that ends in itis means inflammation of. Pharyngitis, conjunctivitis, dermatitis, they all mean inflammation of those organ systems. But if you can imagine, if you have vasculitis, an inflammation of your blood vessel system, your vascular system, that can affect any organ in your body. You know, the biological term for that is broad organotropism, basically that it can infect any organ. You can have not only pneumonia, but heart disease, kidney disease. SARS-CoV-2 can affect your liver, gut, brain, and it can pass from pregnant woman to unborn child. And children, though this is rare, can get serious illness with SARS-CoV-2 related multi-system inflammation. This is the multi-system inflammation syndrome of children, MIS-C, which again can affect any organ in the system. But of increasing concern is the amount of heart disease it can cause that may be permanent, irreversible damage. Fortunately, right now, we are in a downswing of cases in South Carolina. We had a 9-week downward trend of cases after the big surge in January, 2 weeks after the Christmas and New Year's holidays. Unfortunately, it's begun to plateau. As you can see at the very end, this map is showing the 4 different public health regions in South Carolina. It's starting to plateau everywhere. And part of that is a function of Easter, spring break, people getting together, family times, but it's also, we think, a function of vaccinations slowing down, and we'll get back to that. This is just another depiction of our 2-week cumulative incident rates. So these are new cases, and South Carolina is a little bit better shape than the United States as a whole. So again, to put it in perspective, in South Carolina as a whole, we have had, over the past 2 weeks, 108 cases per 100,000 population, slightly lower than the US 113 per 100,000 population. And again, to put it in perspective with what's going on in some other areas of the country, Michigan, more than 4 times as many cases per 100,000. The other good news we have are the number of deaths that have greatly decreased since that peak in mid-January. Again, that's a function largely of vaccination of our older adults, people in long-term care facilities, and workers in healthcare settings. But we're still a little concerned with that plateau of cases. We know the past year has had a terrible impact, not only in number of deaths, but social impact. Visiting restrictions in nursing homes. So many businesses were closed because of COVID-19. Number of schools, K through 12 schools, had complete closures, or they went to virtual settings, including a number of events that had to be canceled, with a lot of frustration in the community about stopping those events. The issues around closing K through 12 schools is not just about education. Many school-age kids relied on school meals as well. And so there was a scurrying to set up other opportunities where kids could still get free meals, kids who no longer had access to nutrition as schools were closed temporarily. We know that these events not only affected K through 12, but certainly colleges and universities. And here's just one simple example from your own university about not only classes going virtual, but other activities, canceling summer mission trips, student trips, the advice against travel to other countries has had an impact statewide, nationwide, worldwide. And in terms of economy, and I know you have a talk later on this, we know that this has had statewide, national, worldwide impact on economy. I want to point out a few of the medical impacts, because it is not only COVID-19 disease, hospitalization, and deaths. There have been other impacts as public health and clinical medicine attention turned to COVID-19, as resources turned to COVID-19, they decreased in other arenas. People's behavior changed as well. As people were afraid to seek healthcare, a number of people avoided medical care because of concerns about contagion. And in this study from the CDC, published in an MMWR, Morbidity and Mortality Weekly Report, 4 in 10 adults reported avoiding medical care because of concerns about COVID-19. That includes delays for people who had multiple medical conditions, diabetes, heart disease, not keeping routine preventive appointments. Some patients were delaying emergency care, and in fact, in this survey a year ago, March 29th through April 25th, compared to the year before, emergency department visits declined 42%. And that led to some people dying at home of conditions that could have been treated. 2020 was also a high, an all-time high in the United States for sexually transmitted infections. We don't think this is because of an increase in sexual behavior, but rather a decrease in seeking treatment for STIs, so that there was an increase in spread of sexually transmitted infections. 41 states have reported increases in opioid and other drug-related overdoses during the past year. And the National Tobacco Quit Line points out that they have had in the past year a decrease by 27%, almost 200,000 calls, decrease in people seeking assistance in quitting smoking. And research shows that stress and anxiety from the pandemic are factors in the increased use of various substances, including tobacco, alcohol, and other drugs. There have been potential impacts of COVID-19 on cancer screening and outcomes. I say outcomes because if you have decreases in screening, you have decreases in early detection, and decreases in those diagnoses, delays in those diagnoses are going to ultimately lead to different treatments. People are diagnosed in a later stage of cancer, we risk having increased cancer mortality. And in fact, it is showing, this was something put out by the National Center for Biotechnology Information around impact of COVID-19 on cancer screening, with more than a third of adults not receiving their recommended screening tests during COVID-19. There were decreases of screening for breast cancer by 87%, lung cancer by 39%, and colon cancer by colonoscopy of 90%. These are really remarkable decreases in preventive care. And not just preventive care, actual cancer care. 80% of cancer patients saw a delay in their health care in receiving radiation therapy, chemotherapy, and surgery. The only good news I have in terms of impact for COVID-19 is that we had a dramatic decrease in the number of cases of influenza in South Carolina, and this was paralleled in the United States as a whole. So what we have here is the curve for influenza cases for multiple years. The red line is the year 2020, 2021. Very few cases of influenza, clearly demonstrating the impact of masking, hand washing, keeping distance on other respiratory illnesses. I want to shift now to talk a bit about vaccine. In this slide, we see all-cause mortality in black, infectious disease mortality in that purple, and non-infectious disease mortality in blue from 1900 to a little bit later than 1980. And you can see that non-infectious causes, cancer, heart disease, stroke, the incidence and mortality rate is about the same. Mortality, certainly we have had medical impact on these diseases by treating them so that mortality was delayed. People had increased quality of life, they could live longer, but ultimately succumb to those non-infectious causes. But when you look at infectious disease, it has plummeted since 1900. And the reason why, maybe in part, improvements in sanitation and clean water, but the biggest impact has been vaccine. This slide, I'm not going to go through all the numbers, but you can see at a glance the number of cases at their maximum in the past century and the number of cases in 2004 and 5, how much vaccine has had an impact in reducing these vaccine preventable diseases. I'm going to switch now to talk about our COVID-19 vaccines. Up in that upper left-hand corner, I've got that image of what the virus looks like under the electron microscope. I do want to emphasize that none of the vaccines that are available now in the United States or that are seeking emergency use authorization from the FDA, none of them contain whole virus. You cannot get COVID-19 from these vaccines. Instead, what they've done is a new technology that is really quite brilliant, and I think is going to take off as the vaccine technology of the future. What they've done is taken just the messenger RNA for the spike protein, just the genetic code for that spike protein, that's the entry point for the virus to get into the cell. Take that genetic code, coat it with some lipids and proteins, I'll show you the ingredients in a moment, inject it into muscle, and the vaccine is then taken up by the immune system cells, it triggers production of the spike protein, which then triggers production of antibodies that's specific to the spike protein, as well as other immune responses, memory B cells and T cells, killer T cells, helper T cells, a wide variety of additional immune responses beyond antibodies. The common ingredients in these mRNA vaccines are simple. There's messenger RNA, that's the active ingredient, but the rest of the ingredients are the inactive, inert ingredients. Basically, they're just to protect the mRNA so it can get into the immune system, that it's not destroyed by muscle enzymes, for example. These both Pfizer and Moderna, the two mRNA vaccines available, have salts, sugars, other lipids, and one ingredient that's probable cause of the allergic reactions is polyethylene glycol. That's a common ingredient in a lot of over-the-counter laxatives. It's found in Colace, for example. This is not ethylene glycol. This is not antifreeze. This is polyethylene glycol. Some people are allergic to it. These vaccines contain no antibiotics, no preservatives, no mercury, no aluminum, no adjuvants. Both Pfizer and Moderna are remarkable in their protection with 95% efficacy 2 weeks after the second shot. And for individuals who are not yet vaccinated, I ask them to put it in perspective. For every decision we make in life, including vaccine, you have to weigh the benefits and the risks. So the benefit of these vaccines, that they're highly effective. What are the risks? I'm going to talk about 3 basic categories. There are the after-shot symptoms, the risk of a severe allergic reaction, and rare events. The common COVID-19 vaccine side effects come from the fact that it is revving up your innate immune system. Some people have fatigue, pain, or swelling at the injection site is quite common. More rarely, some people have fever or chills or a headache. These are all treatable with Tylenol or ibuprofen if you have symptoms, and they only last 1 or 2 days. If you have symptoms from vaccine that last more than 3 days, it is recommended that you see a physician to make sure that there's not something else going on. What about severe allergic reaction or anaphylaxis? About 3 to 5 people per million doses of these COVID vaccines have had anaphylaxis. And in comparison, that rate of anaphylaxis is about 1 in a million for flu vaccine. And it's a treatable condition. So yes, it's something to be aware of, but the risk of serious adverse events with COVID-19 disease is much higher than the risk of an event with the COVID vaccine. We have had more than 175 million doses given in the US as of April 9th. I think we are now at over 200 million doses of vaccine given in the US, with very little in the way of rare events. I do want to mention one in particular. We've not had rare events with Pfizer or Moderna, but we have it for the Janssen or Johnson & Johnson vaccine. The Johnson & Johnson is the parent company. They make a lot of other products. So I refer to this as the Janssen vaccine because Janssen is the pharmaceutical arm of the Johnson & Johnson company. They use a little bit different technology. I liken it to a delivery truck. So they take an adenovirus, a weakened common cold virus, and use it as a vector or delivery truck, carrying spike protein genetic code. They actually use DNA rather than RNA, but again, it is just the genetic code for the spike protein. The nice thing about the Janssen vaccine is it's a single dose. Most people have only mild symptoms after vaccination. It is 85% effective in preventing severe disease and was 100% effective in preventing hospitalization and death, including when it was studied in Brazil and in South Africa, where they have more serious variants circulating. As you probably know, the vaccine is currently on pause because CDC and the Advisory Committee on Immunization Practices are reviewing data. There were 6 cases of a rare blood clotting event out of over 6.8 million doses of vaccine given, and they're investigating it. You may wonder, how do you find 6 out of almost 7 million cases of something. And so I do want to mention the Vaccine Adverse Event Reporting System of CDC. This is the nation's early warning system, and it does an extremely good job at noting rare cases of events for further investigation. I think this is evidence for a robust system of measuring vaccine safety. I do want to finish my talk and leave hopefully a little bit of time for questions by focusing on vaccine hesitancy. This is a survey by Kaiser Family Foundation. They have been doing monthly surveys on vaccine hesitancy since the summer. And this particular slide shows the results of a survey done December, January, February, and March. These are random digit dialing phone surveys. They're different people every month. And they do try to oversample in certain areas of the country to make sure that they are also obtaining information on some smaller subgroups of individuals. So this is overall, you can see that vaccine uptake, the already gotten bar, has increased. The vaccine wait and see, the light blue bar, has decreased with each month. As more and more people are vaccinated, more and more people in the wait and see group are saying, okay, I didn't want to go first. I wanted to wait and see how it's going. And now I understand and want to get my vaccine as soon as possible. But we should look a little bit more closely about who is in that wait and see group. And we'll do that in just a moment. I found this survey done by evangelical Christian leaders who were polled by the National Association of Evangelicals. 95% of those polled stated they would receive a COVID-19 vaccination when it became available, and 89% said they would encourage others to get the vaccine. I've given the URL in case you want to look more closely at this survey. They also recorded a podcast, and I would urge people to go to this podcast and listen for yourself. It's 38 minutes long, but I think a number of interesting points were made by Dr. Francis Collins as he was interviewed. He's the director of the National Institutes of Health, and he himself is an evangelical Christian. And I've just included a few of the quotes from his podcast. In times of plague, Christians have had a tradition of not running away, but running towards it, meaning a plague, meaning any event where they want to be called to act, to love our neighbors in ways we are not used to. He was talking about that usually when you're called to help other people, you embrace them. And now it's so strange. We're being told to love thy neighbor by keeping one's distance, keeping other people safe and not being a super spreader. He talks about, how to distinguish what you hear in social media versus how you distinguish things from factual information. And I really love that he quotes Psalm 46, God is our refuge and our strength and ever-present help in trouble, because he pointed out that it doesn't say that God will prevent trouble. It says God will help in times of trouble. And he does have a section of this podcast. I'm not going to go in detail about it because I cannot convey this better than he does. He talks about the question of fetal cell lines and the ethics of getting vaccinated with these vaccines. Just to be clear, no fetal tissue was used in any of these vaccines, but cell lines that were developed in the past were used to test these vaccines in lab experiments. They were not involved in the production of vaccine. And that he makes this statement. I have quotes around these because I took care to get his words literally word by word copied. Pro-life Christians can be in a position of acceptable ethics and morality by taking advantage of these vaccines, excuse me, to save lives. And he also discusses the ethics of letting the rest of society get vaccinated to achieve herd immunity, but not getting vaccinated yourself. That's not a compelling Christian position. I go through that level of detail because I'm also aware that in this survey of Kaiser Family Foundation, one of the groups that is adamant, that is reporting definitely will not get vaccinated, is white evangelical Christians. I've got an arrow pointing to the fact that, well, 35% have already received one vaccine, which is great. 14% say they will get vaccinated as soon as possible. But there's a large number, and it's not changing as they go month to month with this survey. 28% of those polled in March who are white evangelical Christians or identified as white evangelical Christians said definitely not. 6% said only if required. I would love to hear from you, your perspective. We in public health know that the urgency of getting people vaccinated, because we're worried with these new variants, the more there are delays in people getting vaccinated, the greater opportunity there is for virus to mutate and other more dangerous variants to emerge. So I would love to hear from you. What are the issues for evangelical Christians? Do you have suggestions on how we can reduce vaccine hesitancy? What other information is needed? And any suggestions you have for leadership? How can we set examples that will influence and help others? Thank you very much. I am truly interested in your perspective. And I see we have some questions in the chat room. Someone has posted the podcast. Thank you so much. I should have included that on the slide. I see, does South Carolina DHEC have recommendations on post-acute COVID syndrome sufferers and the vaccine? So you know that the long COVID or long haulers, it's been sort of the nickname for people who had COVID-19, and then their symptoms just seem to hang on for weeks or months. This is a real phenomenon. There are people who have been terribly debilitated for months with symptoms from COVID-19. The good news is there are studies out there now that demonstrate that receiving the vaccine after you have had prior infection does decrease the number of symptoms, the severity of symptoms, the duration of symptoms. So if a person has had prior COVID infection, we are still strongly recommending that they get vaccinated. The vaccine gives you higher levels of neutralizing antibodies. It stimulates your T cells to a greater extent, and the currently available vaccines are also efficacious against the circulating variants, including the Brazil variant, which we haven't described here in South Carolina, but it's here in the United States, and also against that South African variant. So the recommendation for post-acute COVID syndrome sufferers is get vaccinated, and if you get Pfizer and Moderna, get both doses. Make sure you go back for that second dose. I was asking, just before we started, I was asking the session developers about whether you have had a vaccination event on campus. And I know it's the end of the year, end of the school year. There's not enough time to get both doses in, but I know a number of other colleges and universities are having vaccine clinics in which students could get one dose of Pfizer or Moderna. And yes, they'll have to get their second dose at home, but even a single dose of one of those vaccines can confer up to 80% protection. So even a single dose and get your second dose when you go home would be well worth it. And I can help arrange that if there's interest. Can I speak to how commonly we are seeing vaccine breakthrough? We are seeing some vaccine breakthrough, but it's still a very small number. We have had 155 cases of vaccine breakthrough in South Carolina thus far. And just to give the definition, we consider something a breakthrough case if someone has been fully vaccinated, meaning that it's at least 2 weeks after their second dose of Pfizer and Moderna, or 2 weeks after their one dose of Janssen. Had 155 cases. That's out of over 1 million people who have been fully vaccinated. So I'd just like to put that in perspective. We always expected to have some breakthrough cases. That's what 95% efficacy means. It's not 100%. Nothing in life is 100%. So we have had some vaccine breakthrough cases. They are small in number. Most of those cases were asymptomatic or mildly symptomatic. Some of those cases were more serious, but they were among much older adults. They were among nursing home residents who have a much less rigorous immune system. Nationwide, CDC announced, I'm just looking at the numbers, 5,800 breakthrough cases out of more than 77 million people fully vaccinated. So again, we're looking for those breakthrough cases. There are some, but they're really pretty rare. I see someone has written, well, two things. Are my slides available to share? Please share my slides and please use them as you speak to others. Please post them, whatever you can do to try and get the word out, because I think we are at that point where so much depends upon individual to individual communication. It's not messages from DHEC. It's people talking to people. It's local conversations. And I see someone has posted, Robin Vetters has posted, I've had people ask me as a Christian professional what I think about the vaccination. The fact that I've had the vaccine and I'm doing fine affects their decision. Absolutely. People who were vaccine hesitant, who said they were in the wait and see camp, many of them have said once they learned that they had friends and family, they hadn't realized that they knew people who had been vaccinated. We've given out more than 2 million doses of vaccine in South Carolina. It is likely that you know many people who have been vaccinated or at least received 1 dose. Get the word out. That people, if you've been vaccinated, why you chose to get vaccinated and what your personal experience was. What other questions do you have? I see. Oh, good. We've got some other questions. What are my thoughts on whether a heterogeneous vaccination program would have an impact, if any, to public health longitudinally? So the idea here, at least I'm taking this question, is what if you got a shot of one vaccine, like you got the Pfizer vaccine, and then you got the Janssen vaccine, so you're kind of mix and matching. They're studying that. Right now, we are not recommending that because it hasn't been done, so we don't know what might be long-term consequences, what are the effects of that, but I know that that is being actively studied. So for example, the Sputnik vaccine in Russia, they combine 2 different adenoviruses. The one shot is with Ad26 and the other shot is with Ad5. There does seem to be some evidence for a benefit where in countries where this is being studied, and it is being studied in the United States as well. At this point, we are recommending if you started with Pfizer, stay with Pfizer. You started with Moderna, stay with Moderna. They're really very, very similar. I mean, if there was some extenuating circumstance that you couldn't get both doses of the same thing, it's safe to get 2 different doses, but we're not advocating for it as yet. That may change as we get more data. And to public health longitudinally, I know sometimes there have been in the headlines the question of whether we'll need a booster. Nobody knows yet. Right now, the evidence is very supportive for longevity of vaccine, that people still have high antibody levels and strong T-cell function 6 to 7 months after vaccine. And remember, it's not all about antibodies. Antibody levels are eventually going to go down. What's important, though, are the other aspects, those memory B and T cells in your system. People don't talk about that popularly. I think most of the public is aware of antibodies. They haven't heard of B and T cells, but I trust that this audience knows that those other aspects are what's going to keep you safe longitudinally. Will this turn into an annual vaccine, sort of like influenza, that the variants are a little bit different every year? You need a booster every year? Maybe. We don't know that yet. 25% of the deaths reported to the VAERS system occurred within 48 hours of the shot. Any other product on the market with these stats would be pulled. Why are we not talking about this? So I don't know about that 25% of the deaths reported to the VAERS system within 48 hours. I'm not certain of that. What I do know is that there was an MMWR, Morbidity and Mortality Weekly Report, it's published by CDC on the first month of vaccine. So this is from mid-December to mid-January. There were 166 deaths that occurred during that period of time. Half of them were among 70% of them, 70% of them were among people who were older adults, half of whom were long-term care facility residents, people in nursing homes. Now, I might not have those exact numbers. correct, but you can look up that MMW report and I can send the link to that later on. So certainly there have been some deaths in people after they've been vaccinated. I would ask you to look at who died. 166 deaths out of more than 1 million people vaccinated during that period of time. What about the person who gets vaccinated and 2 days later has a heart attack? Is that related to the vaccine? Maybe. CDC investigates all of those to try and see if there is a link. So, 25% of the deaths reported in the VAERS system, I have to look at that data to get back to you. And I would ask people to consider, when you want to weigh pros and cons, risks and benefits, nothing in life is risk-free. Taking Tylenol is not risk-free. The benefit of the vaccine far outstrips the risks.
Thank you so much, Dr. Kelly,
I know we're out of time, and I do want to address the question that is in the chat box, but I can do that. I can do that in follow-up by email and ask you to please share the information I send.
So much for doing that. On Zoom, we'll look at the PowerPoint, take that information with anyone who has those questions. This was very informative and will be very helpful in those conversations about the vaccine, as well as checking out the podcast that she mentioned. Someone put that in the chat in Zoom, and we can send that out after if you're interested in finding that link. So thank you so much, Dr. Kelly, and now we'll turn it over to Dr. Kadio.
Thank you very much. Good morning. It's good to be here, and the Center for Community and Global Health is very pleased to host this second symposium. And we will also like to welcome our symposium participants from different parts of the world. We have people joining us from Côte d'Ivoire, from the Ministry of Health, from Nigeria, from Cameroon, and we welcome all of you. We are so proud of you. We are happy to have you on board. We are discussing a very interesting subject. The question of COVID-19 resilience is going to be the next big chapter in the realm of global health. So here at the Center of Community and Global Health, we want to be front runners in this problematic. So it's very interesting what we have heard so far. It's going to be very good. Stay with us. Those who are willing, at the end of this symposium, we will issue certificate of participation so that you can use it however and wherever you need it. I will be talking about the global health aspect of things. We have seen our first presentation was mostly related to what's going on here in the US, and a very interesting and a very informative presentation. I will add an international, a global health perspective to that, and it's a very interesting what we are going to see here. Some of the things that we have been hearing on the news, we have been reading in research project, we will try to put all of it together and try to make a sense on how we can build an approach to resilience based on a global health perspective. I will be addressing three main questions. The first question that comes to mind is, how did we get to this point? 3 million people dying, and 100 million of people affected by the virus. How did a world that have been sending people to other planets, and with all our global health mechanisms that have been in place, some of those mechanisms have been there since the 1800s, and especially since the end of World War II, all those years that have followed, strong global health and global security mechanisms have been in place. How come have we moved to that point with such a major impact? Because, I mean, as the United Nations was saying, this is over the last 75 years, one of the major events that the world has known. So what happened? We'll be discussing that. Our second question will be, what's the impact on global health security? And I will make sure that I define that notion. And finally, we'll see some ways, we'll explore some ways on how we can approach resilience or recovery. So, this is the outline: security, emergence, impact, and resilience. So I will start first by providing some definitions. It's good for us to kind of agree on some terminology here. Number one, there is a difference between global health as a science and what we refer to as global health security. Global health as a science is kind of a subset of public health that is done generally in specific places of the globe, mostly in the global south, 3 continents: Latin America, Africa, and Asia, mostly in the southeastern part of Asia. And in global health science, we teach our students to address challenges that relate to those countries, which are referred to also as low and middle income countries. But when we use the terminology of global health security, that expression there is very specific. Global health security, I have the definition of the World Health Organization here. Global health security mostly refers to a package, a basket of activities that are conducted on a proactive and on a reactive mode in order to prevent a health threat to spread to all countries, not only southern countries, but to all countries, rich countries, poor countries, to all countries. So what is interesting to know is that in 2014, and this is what the global health community doesn't understand, because in 2014, we went through the Ebola pandemic. And on the aftermath of the Ebola pandemic, the world came together and they worked on what they called the Global Health Security Agenda. What this is, it's a group of 70 countries, and it's expected to grow even. It's a group of 70 countries, the US, China, most of the European countries, coming together and saying, okay, what happened here should never happen again. So basically, they put in place some mechanisms to protect nations in such a way that if there is an infectious disease starting somewhere, that infectious disease does not become a threat to all countries. So this is the global, it's called the Global Health Security Agenda. And I think the US and Indonesia and other countries are part of the steering committee of that program. And the vision, as they stated, is to basically have a world in which it's safe and secure from infectious diseases. And they have a very interesting strategy that has been implemented since 2014 with what they call the Global Health Security Action Packages. Those are different and specific areas and domains in which those actions will be carried to achieve that protection and prevent disease from spreading to all countries. So 8 areas to prevent, to detect, and to respond to global threat. So there is a framework that was laid out. It's called the IHR, the International Health Regulations. And this one has been over since the 1800s. I mean, I'm hearing people saying, they will make vaccines mandatory, we will not be able to travel. Well, mandatory vaccinations have been around for almost 75 years. Actually, there are countries in which you cannot go if you don't have a yellow fever vaccine. It's not something new per se, okay? But that's part of what is called the international health regulations. And as the World Health Organization puts it, until all sectors are on board, no country is ready for the next pandemic. So the question becomes, with all those mechanisms in place, with those countries, those funding, those programs, how did we still manage to have a big pandemic, a global pandemic like this one? And this is what we are going to discuss now. We have already heard about animal reservoir, human victims in the first presentation. So just what I would like to say, we know that the virus moved from an animal reservoir. It could be a bat, it could be a pangolin, it could be minks, it could be, I mean, we have seen even the MERS, the Middle East Respiratory Syndrome, was the coronavirus responsible for it moved from camels, for example, to humans. So it's common. Really, it's common. It's not rare to see viruses moving from one species to the other species. And here, listen very carefully, because there is kind of a confusion that we need to clarify. When a virus crosses what we call the species barrier, from another species to a human species, for example, it doesn't mean necessarily that it's going to trigger a pandemic. It could be an endemic, which means like, it could trigger disease that will be around all year long, no problem. It could also trigger an epidemic, which means like there is an outbreak, a high number, all of a sudden, a high number of cases for that disease. But it doesn't mean a pandemic. A pandemic has its own dynamic. A pandemic has its own dynamic that is not related to the biology of the pathogen. And actually, there is a very interesting work that was done by Brockman and Helbing, I think in 2013, and that they used the word network-driven contagion phenomenon, which means that a pandemic is a phenomenon on its own, and it's driven by factors that are not necessarily borrowed from the biology of the virus or from the health systems in which it's spread. And we'll see this. And when we look at the COVID-19 pandemic, what happened actually, it's a very good illustration of what Brockman and Helbing said some years ago. We can see that, yes, it was a network-driven contagion phenomenon. How? First, we can see the network density. The network density here is global economy, okay? We in global health, we kind of we cover all the area. So let's move to the economic field here. Here is a pie chart that gives how the $88 trillion worth of world economy is distributed across the nations. In red, you can see the US with a share of 25%. In blue, you can see Asian countries and China with a share of about 16%. And then in green, you have European and Middle Eastern countries with a share close to 15%. Very interesting. That's the economic share. In other words, that's the contribution to the global economy. But what is interesting, what the countries that I just mentioned are the countries that have been badly impacted by the COVID-19 pandemic. Asia, Europe, US. So look, if this pie chart gives us the list of countries that have been impacted, and even surprisingly enough, it gives us the list of countries that have not been impacted. Looking at this chart, for example, you can see Africa. Okay, Africa is here at 4 o'clock in the pie chart. At 4 o'clock, Africa is here in purple. Only 3 countries in Africa have a share in the global economy. Only 3 countries. So you have Egypt, you have Nigeria, and you have South Africa. Guess which countries in Africa have reported the highest incidence of a disease? You have Egypt, you have Nigeria, and you have South Africa. And South Africa took a step even further to have even its own variant, the South African variant. How that? Is it a conspiracy to kind of change the world economy as we have heard? No, it's that phenomenon of network-driven that creates the pandemic. In fact, in the global economy, you have what we call poles, places, specific places, sanctuaries, where there is a high concentration of traffic, and those poles are going to work as nodes, and when you have a disease, an epidemic happening in at those nodes, at those poles, the tendency to have a pandemic is very, very high. Just in a very quick comparison, 2014, 14,000 people died from the Ebola pandemic in 3 places of Africa: Sierra Leone, Guinea, and Liberia. 14,000 people. The Ebola virus is highly contagious, highly deadly. 14,000 people, it never became a global pandemic. Why? Because those 3 countries were not poles of the global economy. But what happens with Wuhan, and we have Wuhan is a pole in the global economy, and we have here a model that was done in Germany by the Robert Koch Institute. Very good work using that theory of network-driven. And as you can see here, this is this model here is showing the 4,000 airports and 50,000 routes around the globe of that kind of lead to the global economy. And Wuhan in China is one of those poles. So just 500 to 1,000 cases of an infectious disease at those poles have the high potential to become a pandemic and a global pandemic. And this is exactly what happened. From Wuhan here, you see Wuhan is here on the bottom of the chart, and the model shows if you are going on the left, there is that factor called the relative import risk. The relative import risk gives the likelihood for a virus to spread from one point of the system to the other point, based on the ramifications. Okay, as you can see here, you have the ramification from Wuhan going mostly in Asian airport. You have Hong Kong here, you have Beijing here, okay? And then here, from going on the right, you have one airport here, and this is an airport, this is an important node in the system that you want to protect. You don't have enough coming from Wuhan to this pole here, that's CDG, Charles de Gaulle Airport in France, Paris, okay? You don't have enough coming, but if it comes here, good luck in stopping it. Because you see the ramification, the relative import risk here is very, very, very high. Okay, but even going in the Asian countries, you have one big airport here, the Beijing airport. And when you run the model on the Beijing airport, you literally have an explosion. You literally have an explosion. And this is exactly what happened. This is how we got to the point where we are. From Beijing, you have all the airports in green. Remember those green countries, you have the European countries. Okay, you have US, you have Los Angeles, you have Paris Charles de Gaulle, you have Frankfurt Airport, you have all the German, from Beijing, basically at this point, the pandemic, what was an epidemic in Wuhan became a pandemic, a global pandemic. So that's what makes a pandemic. It's not the biology of a germ, It's the nature of the network, the connection, the ramification in the network that really creates a pandemic. And there is a second phenomenon, very interesting. That one, and guys, as you can see, it's very counterintuitive. You will think that if you have the very benign germ that is coming, that's going to be bad for mankind. No, 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 no. It has absolutely nothing to do with, it has something to do to some extent. But what creates a pandemic is the type of network of spread, number one. And number two is the local behavior. So global economy, local behavior. And there is a model that we really like at the Center of Community and Global Health. It's the health belief model. In other words, it's a necessary condition to have a pandemic. It's a necessary condition that it happens at the pole, at the nodes, and it travels. But another condition, it's necessary, but it's not sufficient. Another condition, it's going to be how local individuals behave. Okay? So if you have, for example, people that do not see the severity of the disease, if you have people that do not see themselves as being susceptible to the disease, there's enough benefit, for example, in wearing face masks or taking a vaccine, or there are barriers that are at the end of, so those factors are going to fashion individual behaviors, and with the network together, you have the bomb, literally. And this is what really happened. And we can see it here in the number of cumulative cases. What we just said explained fully this map. Okay, why the darker, the more number of the higher the number of cumulative cases, and as you can see, Africa has been relatively protected. Actually, there was not even a pandemic in Africa. The definition of a pandemic are not met when we apply it to African countries, except for those 3 countries. Okay. And the reason for that, I mean, actually, back in March 2014, we have friends from the World Health Organization joining us this morning. Back in 2014, it was a big problem. It was a fear. The World Health Organization issued a policy brief saying, African countries, be prepared. Because what we are seeing is bad. I mean, we were all concerned about Africa because we thought that Africa would be badly impacted by this, but it never happened. And one of the reasons, because again, those networks do not apply to Africa. That's number one. Number two, the individual behavior. Okay, I'm not talking group behavior. I'm saying individual behavior, because in terms of pandemic, one person super spreaders, you are familiar with the term. So in 2014, African countries have been through a pandemic. So when they heard that there is another pandemic coming, they were prepared. They knew what the pandemic was. They knew how bad this could be. So the individual behaviors were very, very easy to shape. And this explains that here. Why South African countries are so badly impacted, I think it's not too much of a network, it's because of individual health behavior. At the end of the day, I was speaking, I don't know if they are connected. We should have friends joining us from Brazil. Hey, in Brazil, if you are connected. But I spoke to some friends in Brazil and they told me, yes, there was no Rio Carnival this year, but in reality there was. Because it was canceled, but still the people met anyway. So individual behavior. So yes, so that explains basically the distribution. And very quickly, of the impact of COVID-19. We have heard a lot already. I just wanted to show the different factors that determine the impact for our students. Whenever you are studying something like that, you want to have a good model to approach it. I said earlier that the biology of the virus doesn't matter too much in terms of building a pandemic. But in terms of impact, the biology is going to matter. Okay, you have, for example, and the one thing with coronavirus, I call it a bipolar symptomatology. This is a virus. Someone can catch it, and show absolutely no symptoms. As benign as, I mean, you name it, no symptoms. And just next door, another person can catch it and show symptoms like you would think that is the end of the world. And I think that bipolarity is probably what kind of made us think, oh no, you are doing too much because it's the virus. I mean, it's nothing. And on the other side, you are saying you are not doing enough because the virus is killing us. It's that it's because of the biology of the virus. Okay, so another factor is the socioeconomic factors. Although Africa didn't experience bad cases, numbers of COVID-19, but the impact, socioeconomic impact is going to be even bigger in Africa than it will be in other places. The reason for that is because of what we call the safety nets, the pre-existing safety nets. If, excuse me, if the country has some pre-existing safety nets, then the economic impact will be lower. And then you have also the pandemic response. This one is counterintuitive. When you study the story of pandemics all over the civilizations, actually the recovery, the resilience factor is influenced by the way civilizations have responded to the pandemic. Two things. You don't want to underreact, but you don't want also to overreact. On both ends, it's going to be bad. I mean, let's face it, so there was, for example, some shortage of toilet paper at the beginning of the pandemic. I know coronavirus has some digestive symptoms, but I mean, to the point where we are running out of toilet paper, I mean, we could see lines of people staying in line for 6 hours to have like a hand washer or hydroalcoholic solution for hand washing, and they have soap and water at home, but they leave it and go and stay in line. So the way we respond to a pandemic, it's going to impact also our recovery process, and it's going to influence the impact. Unfortunately, and as we heard, COVID-19, if you don't want it, be isolated. If you have it, be isolated. After you have had it, be isolated. Unfortunately, I mean, the response that has been built around the disease was all on isolation before, during, and even after. And unfortunately, that also will have an impact. And a new one around the table are the media, social media, traditional media. They played a big role in the pandemic, and they are still playing a big role. And I think that a big mistake that we made in global health security is we haven't measured the fullness of influence that media can have on the pandemic. That was a mistake, and that's something that should be corrected. So we have already heard about the impact. I mean, we have 1.6 billion students out of schools. That's a lot. We have social impact, we have economic impact. This is the estimation, 0.7% loss in global GDP per year of the pandemic. Those $88 trillion, okay, 0.7 to 1% of that is lost every year spent in the pandemic. So now we have a memo, no, it's a policy brief from World Health Organization saying that between 75 and 353 million people will fall into extreme poverty in the next coming 5 to 10 years. How do we get out of this? Number one, we have to rebuild public trust. That has been the big problem. The global health security agenda was a top-down approach. Countries got together in 2014, they made a plan, nobody was aware of the plan, and I think one of the worst thing during the pandemic was the loss, the disconnect of public trust between the communities and the decision makers. That has to be rebuilt if we want to explore a way of quick recovery. Now we have researchers calling for evidence-based public health practice, and that's important. transparent decision-making. That's important. And like I said earlier, bottom-up and value-based interventions. We are also calling for a quicker recovery of global solidarity. And by global solidarity, we mean effectiveness of international treaties. There are some agreements between countries. There is a debate. When did China really see the first cases of COVID-19? But honestly, it doesn't matter. The timing is not relevant. From a strictly public health speaking standpoint, it's not that relevant. What is relevant is, why is it that China, for example, when they saw the first cases, they were hesitant to report the first cases? And again, one of the problems is the problem of global solidarity, okay? What is it that, how is the world going to react when I started saying that I have issues in Abidjan, in Lagos, or in Wuhan, I have issues there, okay, oh no, you are on your own. You're on your own. So unless the global health security agenda puts some real solidarity mechanisms for country to feel comfortable to say, hey, guys, I have a problem here. If there is not that security, that level of solidarity, what we have seen, we would see it again, unfortunately. We also need some medical and scientific global cooperation. I'm big on this one because we have seen some things that were kind of very weird. When the World Health Organization issued a statement back in April saying that steroids should not be prescribed, all the practitioners in Africa went like, no, why will you prescribe a steroid during phase 1, the first 10 days of an infection? Well, the World Health Organization needed to make that knowledge because countries that are not facing infectious diseases anymore have kind of lost that knowledge to address infectious diseases. That's the reality. I mean, you see, for example, countries like DRC performing way better than countries like France in terms of managing cases, for example. Okay, the way to do it is just to have enough humility and come together around the table and build scientific and global cooperation and share the responsibility with the people from the press. And my last slide, I've had students asking me what is coming next. We have the next pandemic coming. It has been so. The 21st century has been called the century of pandemics. I mean, we started the century back in 2003 with SARS-CoV-1. We continued with 2012 with MERS, and 2015, 14 with Ebola. Here we are 2019, 2020 with COVID-19. So we will have a next pandemic, but how do we prepare for that? That's the question. Again, bring around the table social actors, communities, white coats, media, early warning systems, and also probably it's time for us in the global health community to start thinking of pandemic education for behavior change. Thank you very much. Oh, thank you.
But a general guideline that is useful is to consider 25 to 35 grams of protein at each meal, and then another 10 to 20 grams for snacks, generally 2 to 3 snacks per day. Some high quality protein sources like eggs, either scrambled or boiled, cheese sticks, Greek yogurt, which has about twice the amount of protein as regular yogurt, and lean meats such as turkey breast and pork tenderloin would all be great additions for a recovering COVID patient's diet. So don't overlook protein shakes as well, which can easily again be sipped on throughout the day. Those made with milk and whey protein are excellent quality and can make up for the lack of appetite for actual solid food. There are a number of ready-made choices that can be purchased, but you can really increase the flavor and the variety of the patient's choices, and really the acceptability in most people's opinion, that is the taste, by making your own with Greek yogurt or vanilla ice cream, or by adding various fruits to a plain vanilla protein powder mix. The ultimate really goal here is just to increase both the calorie and the protein intake. Now, each person is going to be different in their likes and dislikes, so really whatever works for the patient is the best solution. Next of all, support the immune function with adequate micronutrients. There has been so much written over the past year about the importance of boosting your immune function. There are some really key nutrients which play an important role in this idea, but unless you have a true nutrient deficiency, it is generally not necessary or recommended to take supplemental nutrients. Most healthy individuals, however, can get adequate supply of most nutrients that they need through their diets. However, for someone who is in a fragile state of health after an extended battle with COVID-19, higher doses may actually be recommended. So let's start with vitamin C. Men need about 95 milligrams, while women need about 75. For those who are extremely physically active, there is evidence that they may need a bit more, as do those who smoke. However, because vitamin C is water soluble, it is safer to consume much more than is actually recommended, up to about 1,000 milligrams. After this amount, the body can actually reduce the amount of C that is absorbed, and it can also actually cause GI upset. So you don't want to do really high megadoses. With any nutrient, preferable practice is to get the needed amounts through food. For vitamin C, this is fresh fruits and vegetables in all sizes and colors. Additionally, there are other protective nutrients and factors that are consumed with the food that you will not get in pill form. But for someone really who is struggling to get enough calories in a day, like someone who is struggling with the long-term effects of COVID-19 recovery, this vitamin as a supplement would certainly not be problematic. Now let's move along to vitamin D. This vitamin has perhaps been the most discussed in relation to COVID-19 out of all the vitamins and minerals. Now, why is this? Well, it could be simply because we do know that it plays a role in immunity, and we also know that it is one where we see a lot of deficiency throughout many modern societies like the US. There are not a lot of natural food sources of vitamin D. Egg yolks, fortified milk products, and some milk alternatives, some varieties of mushrooms, and some fish like salmon. These are the most abundant dietary sources, but we can also obtain vitamin D from one other important source, and that is the sunlight. Within the body, vitamin D is changed into its active form as it is processed by the liver and the kidneys. However, when someone is seriously ill, hospitalized for weeks, and then recovering slowly at home, the patient is generally not spending a lot of time outside in the sun, even if the weather is pleasant, as it has been lately. So the chances are high that vitamin D deficiency could be an issue. There have been some studies over the last year that's been looking at vitamin D status, and the results have really been quite mixed. The recommendation is still to get a doctor's recommendation after having a blood test to check vitamin D status before beginning to use a supplement. Of the 4 essential fat-soluble vitamins, vitamin D is the most likely to produce toxic effects when consumed in large amounts through supplementation. So it really is a good idea to have vitamin D status checked before beginning any kind of supplemental regimen. And the last one I want to mention is zinc. Zinc is an important mineral when it comes to a healthy, robust immune response. However, it is widely available and spread throughout many of the common foods that we eat. Supplements are rarely needed, and in fact, they can actually cause problems with the immune function as well as interfere with certain medications. Again, the recommendations of the patient's physician or a registered dietitian is a valuable source of evidence-based advice. Zinc status is going to depend on how well someone is eating. So occasionally, a supplement is found to be useful, even if in the short term. If COVID-19 has taught us anything about nutrition, it is this. The basics of good, solid nutrition for health and for healing are as valid now as they ever have been. We need to point patients back to those basics and encourage a renewed reliance on whole, healthy food that can sustain them through a long recovery journey. And I would add this as well. Let's not forget also for those caregivers who are putting in many hours and probably under very stressful conditions, who are caring for a lot of our COVID recovery patients who are now at home. They also need the encouragement to be consuming a good, healthy diet to keep them healthy and strong as they continue to support the lives and the health of their COVID patients. So thank you so much for your attention today. Thank you for attending the symposium. It's been just a pleasure to be able to be a part of it. And now I would encourage each of you to go out and have a really healthy lunch. Thank you so much.
Welcome back. We are excited to share with you a few more sessions about COVID. And this session in particular is talking about COVID long haulers, which is an emerging global issue. So to give you a little bit of my background, I am an assistant professor here in the School of Health Professions, but I also work PRN at a local hospital, and rehab is one of my big areas of interest as well as one of my clinical skill sets. And when it comes to looking at long haulers, those who are having persistent symptoms, one of the first things that pops into my head is, why are they having these persisting symptoms, and what can we do about it? So I'll just make sure. So if we look at some of the big questions about COVID long hauling right now, it's what are the diagnosis, definitions, and phenotypes of this illness that are grouped under COVID long hauling? Because just like those who have moderate and severe cases of the disease, what we're seeing in those that are long haulers, there's a very broad difference in their different persisting symptoms. We also want to know, how long does it last? Who are the ones that are at risk for these serious or prolonged sequelae so that we can come alongside and help them? What are the underlying causes and mechanisms? Because that's going to help us better understand how to address these long hauling symptoms. And really the big ticket question is, how do we prevent or reduce the effects of such sequelae on patient health and well-being? So there is not a clear definition as yet on COVID. This month, the Center for Disease Control did come out with a description of COVID long hauling as encompassing a wide range of symptoms and clinical findings that can occur in people, including patients who had mild or asymptomatic SARS-CoV-2 infections. The United Kingdom's National Institute for Health and Care Excellence came out with some guidelines at the end of December, and they said COVID long hauling can fall into two main categories. The first category is ongoing symptomatic COVID-19, which emerges about 4 to 12 weeks after the experience with COVID. And there's also another group of COVID long haulers which are having much longer persisting symptoms, and they call this post-COVID-19 syndrome, where these patients are having symptoms more than 12 weeks after having COVID. There's still a variety of statistics on COVID long hauling. There's some good research out of the UK that says 1 in 5 individuals that have COVID and more of that mild case of COVID is still going to have symptoms at that 5-week mark. And about 1 in 10 individuals will have 1 or more persisting symptoms at 12 weeks or more. Generally, the literature says 10 to 35% of individuals who have a more mild case of COVID will have COVID long hauling. And they suspect, because of some of the subtle differences in symptoms, that some of these patients know that they're not back to normal, but they don't realize that they're still experiencing these persisting effects to the level at which they are. And that probably leads to the question of who is going to persist in long hauling. So there was a study done in the United Kingdom, United States, and Sweden, and they use a COVID symptom tracking app. And individuals went ahead and prospectively reported their symptoms. And these researchers were looking at what are the risk factors for developing long hauling. They found that 13.3% of a group of over 4,000 individuals had persisting symptoms at more than 28 days post, and that some of the predictors for that persisting were having more than 5 symptoms within the first week of COVID, and those particular individuals are 4 times more likely to have long hauling. The symptoms that especially put them at risk were the combination factor of fatigue, headache, shortness of breath, a hoarse voice, and pain in a muscle or group of muscles. If they looked at the demographic characteristics of these long haulers, they found that it was more likely to be women, individuals who were older, and that looked at middle age and above, and those who were diagnosed as obese. And that was in our nutrition talk, we talked about the risk factors of how obesity impacts health. Long hauling symptoms are broad and diverse. However, there's 4 key systems in the body they address, and that's our neural system, pulmonary system, cardiac, and gastrointestinal. And the neural system in particular and pulmonary are 2 of the most prominent that we've seen in this pandemic. If we look at the specific symptoms, they're broad and diverse, and a lot of patients that are long haulers report that these symptoms are intermittent and then relapsing and how they appear to them. Researchers have started to look at, okay, what symptoms are people having more commonly, and how can we address rehab programs or help them to recover these symptoms? There was a study done of over 1,000 healthcare workers in Sweden, and these individuals were voluntarily recruited. And one of the key things they wanted to find from their study was not only what symptoms do these individuals display if they're a long hauler, but secondarily, what immunity do they show? And they found that in this group of over 1,000 individuals, only about 75% of them were seropositive or carried that immunity for a long time afterwards. But there are these 10 symptoms that were persisting at more than 6 weeks after their experience with COVID. So when they studied these seropositive versus seronegative, you could see the numbers at 2 months, 4 months, and 8 months. And the numbers of these healthcare workers who are more in tune with persisting symptoms, it's kind of staggering that they had at least 1 moderate to severe symptom at 2 months to the 84% level or 95%, and vice versa. What I thought was very interesting in this data, at 8 months, about half of those who had immunity were still having 1 moderate to severe long hauling symptom or more. But those that didn't have the immunity left, they were seronegative, only about 36% of them had this persisting symptom. So we're not quite sure the mechanism of why that's there, but it's an interesting finding. So what were these moderate to severe, really persisting symptoms? The 4 top ones are the loss of taste and smell, fatigue, and difficulty breathing, which have a significant life impact. So this study kind of concluded that there's a considerable portion of low-risk individuals who have mild COVID-19 cases but they report a diversity of long-term symptoms which disrupt their work, social, and home life. In this case, they were some of the very workers helping to assist those that had COVID-19 and help their country recover. In the United States, we were really looking at the research coming out of China and Europe. And what we were seeing was that there was a lot of neurocognitive deficits. So Northwestern University decided to open a neurocognitive clinic to look at these more specifically, how frequently they're occurring, and how do patients respond to treatment for them. These were individuals who were mild. They reported transient respiratory symptoms, if respiratory symptoms at all. So those that had more pulmonary complications were not in this group. They had an in-person clinic, but they also saw patients from 21 other states in the United States. And they only include the first 100 people who presented at their clinic who also wanted to be in this research study. So they reported both the neurologic and non-neurologic long-hauling symptoms these individuals face. And they found that 81% of these 100 individuals, so basically 81 people, said they had brain fog. About 85 of them had fatigue. And there's just a variety of other symptoms as well. So these individuals were pretty debilitated, and it was drastically impacting their quality of life. If we look at a comparison between more severe COVID cases and these mild cases that turn into long hauling, it's interesting to look at that 82% of those that have a more severe case of COVID end up with neurological symptoms. And we had the brain fog is at 81%. So why are we seeing similarities when we had such mild cases of COVID versus those that had such severe cases? Another key finding was that these individuals that were COVID long haulers had marked differences in scores of attention and working memory. So what that indicates is that those who've had COVID and maybe had those more mild cases and may have persisting symptoms, we can use screeners of attention and working memory to determine if they're at risk or even have other persisting long-hauling symptoms. There was generally a moderate quality of life impairment due to those cognitive deficits and fatigue the patients were experiencing. So they really dug into some of the underlying mechanisms that could be at work behind severe COVID versus a long-hauling syndrome. And we know those that have severe COVID tend to have some sort of underlying respiratory, cardiovascular disease, diabetes, or hyperlipidemia, or some tendency toward those. What we saw in the long-hauling community was that there seemed to be some sort of autoimmune condition that might have interacted with some pre-existing tendencies that they had. And then there were things like inflammation of the endothelial cells in the brain and some microvasculopathy as well in the blood flow to the brain, which we could see from some other studies kind of matches up what we're seeing in the symptomology. They suggested that we might consider long hauling a form of post-acute encephalopathy. So encephalopathy is basically inflammation of the structures of the brain, which those endotheliitis and microvasculopathy would explain. So COVID has had a big multifactorial impact on our healthcare system and on the individuals. And if we look at these long hauling symptoms, it's further showing how important these social determinants of health are, especially to those underinsured or uninsured populations and those from minority groups. Those that have persisting long hauling symptoms like that brain fog and fatigue are at high risk for not being able to fulfill their work obligations or work a full work week and then not bring that income into their family and or maintain a job in this tough economic environment. Our last session dealt some with that nutrition aspect. Well, we know that these individuals, as they're recovering, their body needs greater nutrition. But if they don't have a sense of taste and smell, and some of these individuals, it's 8 months after their experience with COVID, if you don't taste or smell, you're probably not going to get very much enjoyment from eating. You're probably not eating as much. How much of that is interplaying with the continued symptomology we're seeing? And these individuals are really at risk for chronic disability, which is a very sobering thought. In general, the pandemic has created a lot of uncertainty and unknown, and those that have severe COVID and those that have these long hauling symptoms, there's been some good research studies to kind of look at how can we help them rebuild, gain hope. And Berger Clark, who's a licensed social worker, said, finding strategies to expand and accept the resilience has been the biggest success in treating the emotional limitations of COVID survivors. And one of the other things that we've done in my rehab facility is that we tend to see more moderate to severe COVID recovery cases, but we ask people who've recovered very well and had the severe forms of COVID to come back, and then encourage those who are still in that rehabilitation process of what is happening. And maybe we need some support groups and other things in the community to show what is possible. Rydberg, who is a physiatrist or a rehab doctor, said, we need to continue to learn about the long-term consequences of COVID and how we as rehabilitation professionals can find ways to collaborate and create solutions for responding to this novel coronavirus. And once again, if you look at our hospital systems, yes, there's been so much innovation, there's been so much greater teamwork to really address these more severe patients. Now we kind of need to retool and look at what can we do to rehab our population as a whole, especially these long haulers who are facing the unknown, the uncertainty, this chronic disability. And there are statistics out there. There's still a lot of statistics emerging about COVID, but what we do know about rehab is you don't know until you try. And there's a lot of things that work, and we'll talk about some of those statistics in a little bit. So we mentioned that smell and taste changes and how significant that is to nutrition as well as quality of life. It seems like it's one of the most prevalent symptoms that people have with COVID. And these are patients that are symptomatic and asymptomatic. There are some studies which suggest it might help us actually determine who are some of those asymptomatic people that get COVID. In general, these smell and taste changes are more correlated with a milder version of COVID than those severe cases of COVID that individuals are getting. In a meta-analysis study done on post-viral olfactory dysfunction, they looked at olfactory training, and they looked at both classical or traditional and modified versions of olfactory training. And they found that patients that had been through this olfactory training, who had lost their sense of smell through various reasons, 60% reported improvement. So 6 out of 10 people who went through these treatments did improve. They found that a longer duration, which in the research studies, there was a duration of 3 weeks all the way through 8 months, but the longer duration of olfactory training, the greater improvement in results. They also found that those who went through this olfactory training were 3 times more likely to have a clinical difference on future scientific tests of their olfaction. So that is pretty encouraging that there is a significant difference from some of these tests. And I think it would be interesting to start looking at this in different volunteers and seeing how we can help those. So this is where it really gets interesting. It might get a little scary. So the question came about as, so what's causing these long hauling symptoms? Why are we having it? And we talked a little bit about that inflammation of the endothelial cells, possibly those vascular changes. Well, they started to look at PET and CT scans. So this is really looking at the metabolism, the energy engagement level of the brain. And so there's been 2 main research studies that were very recently published, and they looked at, they had a control population. One group had cancer patients, and then the other were the long haulers. And so they both had a control group of some sort, and they looked at their symptomology, and they looked at their brains and what areas lit up. And they found generally there was a hypometabolism, a lower energy level in some of these specific areas. So Solini and his colleagues found that there's a bilateral parahippocampal gyrus and orbital frontal cortex lower activation that really corresponded with that taste and smell changes. And another group found that there were also similar things in the cerebellum. And the cerebellum is a feedback loop for a lot of motor and sensory loops in your body. So it's interesting, probably anywhere that taste and smell goes in your brain, either the main processing areas or those connections are being affected by COVID. There's some that were identified in the vascular uptake, and then with the fatigue and even those dysautonomia, those autonomic nervous systems, autoimmune system things that we're seeing. That is very interesting. Your thalamus, which helps as a sensory regulation center of your brain, does your sleep wake cycle, your alertness. It works with your hypothalamus on their sense of hunger, that it was connected with these. So that just makes sense, because what I've seen in subcortical stroke patients, they also sometimes lose their sense of taste and smell, and we can often rehabilitate some of that as well. And they also sometimes have insomnia, and getting enough hydration, being on a sleep schedule, different things like that have helped that population. So it could help these populations as well, because we're seeing not the same, but at least hypometabolism, under energy of these certain areas of the brain. So if we look at a comparison between what we're seeing in the blood studies, what we're seeing in the PET scans and those other things, we can compare the symptomology we're seeing in COVID long haulers as those two within encephalopathy, which encephalopathy is like an inflammation that tends to recover, or some stroke cases. And we know that one of the side effects of having COVID can be mini strokes. It can be atrial fibrillation, some other things. And or one of the most common connections has been potentially a mild traumatic brain injury, something similar. Mild traumatic brain injury is a concussion. And so we have some similar symptomology. But we have a lot of research in these other areas about how we can rehab and how we can help, which we can then retool for this population, which is exciting. Dr. Julius Friedrichsen, which is the director of the University of South Carolina's aphasia laboratory, has redirected his laboratory to looking at COVID long hauling. He has currently recruited 100 individuals who are 20 to 77 years of age and are having long hauling symptoms. And he found he does a lot of MRI work, and through his MRI work, he's found that one of the underlying causes of these persisting symptoms seems to be some small vessel disease, mini strokes, and damage to the white matter connection. So once again, we have this hypometabolism, not as much energy or activation of these areas. So what do we know about rehab? We know that there's a thing called neuroplasticity. Neuroplasticity is a fancy word that basically that your brain is designed to heal. There's going to be some healing that takes place when anything happens in your brain without you having to think about it. Nutrition can aid that brain healing. If we look at the rehabilitation literature, we know that therapy works. What therapy does is we increase the metabolism of those underutilized areas of the brain. They've been MRIs and PET scans and other things that show before therapy, there's this hypometabolism, low blood flow, and then after therapy, now you have greater activation of those areas. Therapy produces better communication skills, and that includes that attention and that working memory that a lot of speech pathologists deal with. That therapy given during the acute stages does produce the greatest gains. So that's interesting with the COVID long hauling population. We're starting to have studies that are looking at these individuals, and they're 2, 4, 8 months after their experience with COVID. So that really indicates that we really need to jump on this and start facilitating treatments and recovery so that they get full and maximum recovery. We know that treatment produces a certain degree of lasting effects. So some of these symptoms they come and they go a little bit, but what therapy does is it rewires the brain so they can persist. If we look at the chronic stroke therapy literature, we find that even those who are a year, 2 years, and even 5 years out from a stroke, there are some of those patients that still with rehab, with facilitation, gain greater brain recovery than those who do not have treatment at all. Some of our general benchmarks for recovery and neurologic improvement are the 1 month after the brain injury, the stroke, whatever, at 6 months after, and at 12 months after. So those first 6 months are really key in the recovery, and then it starts to slow down. We're finding out a lot more about some of the mechanisms behind COVID, but especially this COVID long hauling, we just have some initial evidence. So we don't know if this would be the same timeline or if it might be more 18 months. 2 years would be a better timeline than 1 month, 6 months, and 12 months. What we do know is we need to have a consistent, clear definition on COVID long hauling. And then we need to get that definition out to healthcare providers, connect it with some of this literature out there about what we can do, comparison populations, and then design multidisciplinary interventions so we can fully address the symptomology that patients are experiencing. We need to appropriately diagnose and treat this population. We have retooled our healthcare systems. I know even the hospital I work at, we still have some of our outpatient facilities being used as inpatient facilities. And I think at this point, it's some of those health conditions that weren't dealt with during the pandemic, that those patients now are sicker and coming to the hospital and needing greater levels of care. But a lot of these patients are at home, so we need greater outpatient rehabilitation facilities. We need clinicians who are specialized and or trained or have the latest evidence to really provide good evidence-based treatments for effective and efficient recovery. We need insurance companies to recognize this, to reimburse. There's even grant agencies to really look at this as a public health, a significant public health concern that maybe even is greater to a certain extent than diabetes and some of the other factors that we have seen, because of how significant the numbers are of those with long hauling symptoms. So general recommendations. What can we do besides really look forward to, let's study these populations out. Let's implement some olfactory training, address the symptomology. Well, we need to really make sure we're listening to patients and understanding their concerns. We know one of the things that has emerged from this pandemic is people aren't as trustful of the healthcare system. They don't know who to trust. There's been so much information in media and social media. What is true and what is accurate, and why are they persisting in these different deficits? And it's not just because there's been the isolation from the pandemic and so many lifestyle changes. We need to validate their experience, but help them understand what is going on in their body and what we can do about it. As healthcare professionals, we need to manage their symptoms and their comorbidities and refer as necessary to that proper healthcare providers. All of this is kind of guided by a clear definition of COVID long hauling. What is it? What are the parameters, benchmarks? You know, is it 3 weeks, 4 weeks, 6 weeks after? We're not really sure, but we know 4 to 6 weeks seems to be a good estimate. But then how far out does it become a post-acute syndrome? We need to provide discharge patients, and this is more those moderate to severe cases that went into the hospital with COVID, with long-term access to interdisciplinary care, because we know that it's had a significant impact on their lungs for some patients and on these different brain regions. We need appropriate public messaging about who this affects, not, oh no, you've had these brain changes, these body changes, but COVID can cause long hauling symptoms. Here's what you could do about it. Here's the healthcare professionals that can help. And then there's been a lot of refinement of our healthcare system, but because these patients are mainly going to be outpatient, because they're going to have a lot of specialized needs, maybe we need to imitate the Northwestern University Hospital's outpatient neuro-COVID clinic and start more of those clinics with professionals that are educated in them and make networks within our hospital systems in that interdisciplinary practice to really ensure that the general public has their needs met. But we've seen in different research studies and just talking with people in the healthcare community, we know that healthcare workers have been disproportionately impacted by COVID as well. So we really need to make sure that our healthcare workers who've given so much have their long hauling symptoms needs met and are completely rehabilitated. So there's a lot of information quickly. Does anyone have any questions? Not that I've seen. It does seem that nutrition plays a significant role, and also our next session is on fatigue, and so I think we're going to hear some good tips about what you can do to really, a lot of times in rehabilitation, when someone's recovering from an illness, it's paying attention to your body to know when you should stop. So some of these patients are a little bit more fragile. So when they're starting to have an emergence of symptoms, rather than pushing through, they need to stop and rest and really make sure they have their nutrition needs met so their body can heal versus going into overdrive to keep them going, which is going to interfere with their healing and contribute to those long hauling symptoms.
So there are a few more questions in the chat here, but we're out of time for this session. So if you wouldn't mind contacting them.
Okay, that sounds good. I think I went over, but thank you for your questions. And we are excited to have Dr. Stephen Chen speak next.
Good. Well, hello everybody, and people online as well, and welcome to this symposium, and happy to be here to talk about fatigue today as one of the symptoms. Kind of really follow up what Dr. Benge is talking about so far. My area is studying exercise physiology and fatigue and performance, and so this area is very intriguing to me as far as how it can help patients to recover from fatigue following COVID. So what is fatigue? We all have experienced fatigue, right? On a day-to-day basis, fatigue from a workout, fatigue from having a big meal at lunch today, fatigue from the symposium with the information overload. But the fatigue that these patients, the long haulers, are experiencing is somewhat different than the everyday fatigue and tiredness they would feel at times. And sometimes it's not reversible by rest. Okay, so there's feeling this chronic fatigue for weeks, or it could be after many, many months as well. So why is it important? Because like Dr. Benge said earlier, this is one of the symptoms in long haulers that can have a tremendous negative impact on everyday life. Think about your social interactions, family functions, work, you're going through school. So that can have a tremendous impact. And we definitely need to increase awareness of this in a way to intensify the research studies, to identify what causes the fatigue, and then we can devise strategies to delay the fatigue in these long haulers. So fatigue in general is an invisible symptom. It's common in many severe diseases, cancers, several autoimmune diseases, and some of the neurodegenerative diseases like Parkinson's disease, and as well as Alzheimer's disease as well. Okay, it is also a common symptom in multiple viral and bacterial infections. So it is a normal part of the body's response as an inflammatory response to fight infection. So it's okay to feel fatigue. It is okay to lay on the couch for a couple of days or sleep in your bed, because that's a normal, healthy response of the immune system in a way to conserve energy reserves, okay? Reserves to help you to fight through this infection. So once the infection is done, the fatigue should go away. So the type of fatigue we'll talk about today is the post-viral fatigue. Okay, it is not surprising that the post-COVID long haulers will experience a prolonged, debilitating type of fatigue because it is observed in other viral infections as well, such as the list you see on the screen here. Okay, whether it's a bacteria or viral infections, some of the patients can experience fatigue for weeks, if not after months. Now, with the studies I'm going to show you, is that the fatigue is the most common long-term health issue that the long haulers are facing. And this is the, let's talk about some of the studies here. Two studies that I point out here. Number one is a small-scale study that was done early on in Rome, in Italy. The age of this group is about 56 years old, and they were assessed during the acute phase of COVID. You can tell that these are the symptoms. It can generate about close to 30, 40 symptoms, as we know from Dr. Benge's talk already. But they will follow up about 60 days after they recover from the COVID, so 2 months after. And you can tell so far is that 53% of the patients still reports the fatigue, along with this dyspnea as well. And they also reported a very poor quality of life. Okay. Another study done in Wuhan, China, where the virus was originated. This is about 1730 patients here, and their mean age is about 57 years old. Half of that patients are less than 57 years old. Okay. So they were followed up 6 months after they recovered from this acute infection. And what you see is that the majority, 63% of these patients, 6 months after, okay, still experience fatigue or muscle weakness, along with some of these sleeping disturbances. So these studies, along with many others, have done around the globe, has shown the fatigue is the common symptom they're all going to face as a post-COVID long haulers. So how long would this last? And there was a question asked by Dr. Benge. We don't know the answer to that question, but we can examine other studies have done to capture the long-term consequences of another coronavirus known as the SARS. There was a SARS outbreak back in 2002, 2003, and there were a few studies have captured be able to follow with these patients, the survivors, and to look at the symptoms as well. So here are two studies. There are actually a few more, but the studies on the left is look at a small subset of patients. It's a case control study done in Toronto. About 23 patients there. And these are mostly females, healthcare workers, and about 60% of those healthcare workers experience the fatigue, persistent fatigue, for about a year after they recover from the infection. And the study on the right is look at the SARS survivors in Hong Kong. There were about 243 survivors were in this study, and they were followed up to about 4 years. Okay, and they recover from the infection. And again, 40% of the survivors experienced that, again, that prolonged chronic fatigue. So it's not encouraging news. And my wife is one of the post-COVID long haulers. I haven't told her about these studies. And she has gone through 3 months of this post-COVID symptoms, including fatigue, shortness of breath, and chest pain. So it could last up to a year, or even 4 years, based on these studies. So it's really important, again, one more time, the key is to make sure that the scientists are ramp up this research, not just to prevent the COVID, but also to treating the morbidities of the COVID as well. So another question that was brought up early on this year is about, will COVID-19 lead to a symptom called myalgic encephalomyelitis, which is known as CFS, chronic fatigue syndrome. And Dr. Fauci has talked about this early on in the conference, that patients with post-COVID-19 can develop a post-viral syndrome that is very similar to this myalgic encephalomyelitis, and which is CFS. Okay. So what is CFS? CFS is a complex illness, and this is the criteria to diagnose someone with CFS. It takes a while to do this because you have to really make sure to get the in-depth history, medical history and health history, to cross off any symptoms and diseases, conditions that may generate the fatigue first. And then the criteria here would be not able to participate in routine activities that is possible becoming ill, and that has to last for at least 6 months, okay? So at least 6 months to be diagnosed as CFS. Other is the PEM, post-exertional malaise, and we'll talk about this in a second. Unrefreshing sleep. So those are the 3 criteria, and then at least 1 or 2 on the bottom, which is impaired memory, unable to concentrate, and maybe with the orthostatic intolerance as well. So it's very similar to the post-COVID long haulers, what they're experiencing as well. So just a quick slide on the CFS here. CFS, it's been estimated to impact 800,000 to about 2.5 million Americans. We think that with this post-COVID long haulers, if they go long enough, you will see the increased number of cases of CFS in the near future. This is most commonly in people between 40 and 60 years old, affects people of all ages, more women than men. About 90% of the people with CFS have not been diagnosed. And this is a very interesting point because this illness is often misunderstood. It's also not highly discussed or even taught in some of the medical schools. So there's a lack of education among physicians to treat and diagnose CFS. So I think it's very important that we need to make sure that the healthcare providers, or doctors and nurses, are highly educated in this condition, because they will face maybe more cases coming from the post-COVID. So what causes the post-viral fatigue syndromes, the CFS? Now, with the presentation coming, that was early on by Dr. Kelly, and she did a great job talking about, since this is a multi-system diseases, the COVID can impact any systems and organs in the body. So if during the acute phase, if the patient has suffered damages to the heart, the lung, the kidneys, and certainly that can generate the fatigue with that. Folks that have gone through maybe in a hospital, going through hospitalization, if some have gone through ventilation and to get over the COVID, and if still experiencing the persistent symptoms after the discharge from the hospital, and that can also lead them into depression-like symptoms, and that can also generate fatigue as well. So there are other factors involved, and it's a very complex phenomenon when you talk about fatigue. So what if the patient, okay, has no documented heart, lung, or kidney damage, and they had mild symptoms early on? So what could explain the fatigue and other symptoms? And there are a few other possible explanations out there so far. And one would be a chronic low-grade neuroinflammation. Again, as with the early on presentations from Dr. Kelly, she talked about inflammation as part of this acute phase COVID. Inflammation can also happen in the brain because the virus can also infect the brain as well. And this is characterized by increased production of cytokines when you think about inflammation. So the cytokines, there are about 200 cytokines, and certainly one of the functions is to produce sickness behaviors. And that would include a loss of appetite, sleep changes, lack of interest in anything else. It could be lack of appetite as well. So there are a lot of behaviors included, and fatigue is a major component of sickness behavior. So a scientist at the University of South Carolina, and his goal was to study fatigue, and he used an exercise stress model to induce inflammation in mice. So try to bear with me with this study here. So we want to look at what factors causes fatigue, and fatigue is a complex phenomenon. It is an interaction of central and peripheral factors and psychological factors, but using basic science experiments in animal studies, we can tease out this individual factor and see how these chemicals can cause fatigue. So here is an exercise stress model. The scientists have two groups of mice. One group is going uphill, and the other group is going downhill at a pretty fast pace, and they're going either 14% on incline or minus 14% on a decline for about an hour and a half. So downhill running versus uphill running. Nobody likes to run up the hill, I would assume. Okay, it's hard, it's fatiguing, and it burns a lot of energy, it burns a lot of calories. But it does not produce as much muscle damage compared to downhill running. Now, when you run downhill, your heart rate is lower, it's easier, you're loving it. But if you do this for a prolonged period of time, you can damage the muscles because there's a lot more eccentric contractions that's happening when you're running downhill. And so every time you take a step down the hill, you're braking from falling forward. So that eccentric contractions is what causing the muscle damage. As a result, causing inflammation and then muscle soreness afterwards, along with functional deficits. So he put these two groups of mice. They ran uphill one time, they ran downhill one time, and he looked at the brain and the muscle as well. And he basically focused on a interleukin-1 beta, one of the cytokines. And what he saw is that this is a data from the brain regions in mice. So you're looking at different colors here, but the red color versus the green is what we're trying to focus on. The red color is the downhill running group, and the green color is the uphill running group. And you're looking at this is the 24 hours, 48 hours post the exercise on the treadmill. So compared to red versus the green bar, as you can tell is that the downhill running group produced a significant amount of IL-1 beta, a cytokine, in the brain regions, in the cortex, and the cerebellum, compared to uphill running. So this is really cool data. It's really one of the kind to look at inflammation in the brain. And we can't do it in humans to cut out somebody's brain and look at the inflammation markers. But using animal studies, we can understand further what the markers are doing in the brain. So this is correlate with a voluntary performance. So this is a wheel running apparatus, and you put one mouse per cage. They're well fed. It's almost like they're in a hotel. They'd be well fed. They're in a nice bed, and mice love to run on the wheels, okay, just like hamsters. So these are all connected to a computer system to measure the speed, the distance of the wheel running. Okay, and after they ran uphill, and after they ran downhill, so these two groups of mice, and we're looking at the voluntary wheel running performance. So you're looking at this is the baseline on the left side here. So this is assuming these two groups of mice love to run. They were at 100% capacity when they're running the wheels. Okay, but look at the daytime after, let's say 1 day after, 2 days after, 3 days after. What you see is a big difference 1 day after and 2 days after of the uphill versus downhill running. If you look at the difference in the bar and the color, is that the downhill running group, they dropped their performance on the wheels from 100% down to about 30% 1 day after. Okay? And 2 days after is about 70% lower than baseline. So again, this is to correlate the inflammation that's happening in the brain indicated by the elevation of IL-1 beta, the cytokines, is highly correlated with this drop-off in this performance of wheel running. And we interpret this as a lack of motivation. Again, these mice love to run on the wheels, but they're having a lack of motivation, less willingness to run, to be active. So that was one explanation of what could cause the fatigue in these post-COVID long haulers. And there are other explanations as well, increase in oxidative stress, increase in mitochondrial dysfunction, and you mentioned about the hypometabolism in the brain that can also link to the mitochondrial dysfunction as well. So a lot of other explanations as we hope to find out more and more about this. And again, the key is once you know the cause of the fatigue, we can devise strategies to help delay and to treat the fatigue in the long run. But at least what we know is that exercise training, being regularly physically active, has multiple health benefits in the body for different systems, as well as in the brain, as well as if you look at the green area here, these are the health benefits well documented in the brain. Okay, so if you basically are engaged in low to moderate intensity exercise, 30 minutes a day, 5 days a week, you basically can achieve these health benefits, improving memory, learning, improve immune system, improve genesis of neurons. And the most important component is it has an anti-inflammatory process in a way to increase those anti-inflammatory cytokines and reduce the production of those pro-inflammatory cytokines. Certainly, being physically active is key to prevent any deconditioning. So think about for the post-COVID long haulers, if they feel the fatigue, they just want to stay in the bed. Okay, they just want to stay on the couch. But the key is be able to get them off the couch and be active to some extent. And any deconditioning, as you can tell from this little graph up there on the right, this will become a vicious cycle. Once a person becomes inactive, that can develop, for example, sarcopenia in aging population. There's a loss of muscle mass because of the aging. So physical activity can slow down the sarcopenia to help maintain muscle mass and therefore muscle strength and muscle endurance, and therefore decrease frailty and maintain their quality of life by maintaining the optimal physical functioning, especially in older adults. So a study that I found is probably the only study that's established so far to look at the impact of rehabilitation in post-COVID-19 patients. This is a case study, and this have 7 patients in this study, and they were discharged from the hospital, and they were put in a outpatient rehab clinic for about 3 months. As you can tell, these are a lot of numbers here, but I want to show you is that they measure the baseline on the top of the chart here, and on the bottom is the looking at the post measures. They looked at 6-minute walk test, how far they can walk in 6 minutes, how fast they can walk in 10 meters, some of the short physical performance battery, and they also looked at the fatigue scale on the top. So just quickly summarize this table is that they have seen a dramatic improvement for the fatigue level has gone down after the rehab, and also the physical functioning has improved since day 1 of the discharge. So it is exciting data. However, it does require a randomized controlled trial to confirm these findings. So let's talk about the recommendations for physical rehab or exercise programming. The emphasis for the post-COVID long haulers is not to improve the aerobic capacity or to improve the muscular strength and endurance. The key is to help them to delay, to attenuate that perception of fatigue, and also to get them to be active enough to maintain or improve their functioning as well as quality of life. So it's a very different approach than you're not trying to train somebody to run a 5K or 10K here. You just want to help them to get through and as they experience the fatigue on a day-to-day basis. So it has to be gradual, planned, and the key thing to highlight is to progress someone is to make sure you increase the duration first before you increase the intensity. Duration will be the time maybe on the treadmill, maybe the time on the bike. Before you ramp that up, to have them go run up the incline or bike up a very steep hill. Again, the key is to go slow and very gradual with this approach. So just a quick recommendations on some of these mode of exercise. Aerobic exercise, you can do anything you want, but certainly walking is the easiest mode. That's doesn't require the equipment. You can do it anywhere. Strength training, you can still get these patients to go through strength training, but the key is to make sure that we're not trying to improve their muscular strength or endurance. You want to help them to maintain that level, okay, so they can continue to function optimally on a daily basis. And the key is not to get them to a muscle soreness. So if you have them do a new exercise, or they go to more than 60% or 70% what they can do maximally, now you induce that muscle soreness and the fatigue comes in, and this is when they will be off for at least a couple of days to try to recover from the soreness. Flexibility can also help them to do stretching, things like yoga as well to help preserve that range of motion. And again, the key for these post-COVID long haulers is to go slow and gradual increase, because if you go too fast, too strong, they will experience this post-exertional malaise, it's the PMM. So the flare-ups is what you don't want these patients to experience. Basically it's defined as worsening of the symptoms. That could be the fatigue, the pain, muscular ache, and that can go on from 24, 48 hours post, sometimes even lasting for weeks. So the important highlights is that for the post-COVID long haulers, or even for the trainers, rehab specialists, exercise physiologists, the key is to make sure that they don't experience PEM. And they have an important job to make sure that the program they're writing it's got to be slow and gradual, like I said, and it's to make sure that they don't get dropped out of the program, or maybe just not be able to adhere to the program, and they're missing for a week or two because they're sore, they feel the fatigue, and their fear of coming back to the rehab. So it's better to err on the side of doing too little on any one day. And so one of the strategies for these long haulers is for them to understand that energy is required not just for physical activity, but also for mental activity as well. So if you're doing 3 hours on the crossword puzzle, working on your final paper, anything that requires energy, okay, and mentally as well. So we want to make sure these post-COVID long haulers learn how to pace themselves, intersperse work with plenty of rest periods. Again, is to try to avoid the overexertion and the PEM. There's a lot of trial and error here. There's not a formula here, but everybody is different. The person needs to find what is the baseline and what is the limit for these mental and physical activities. And it'll be even beneficial for them to use a diary, a log to put down activities they're trying to do throughout the day, and to make it very structured so they can monitor the activity. By using what is a heart rate monitor or a perceived exertion chart. So since everybody have access to heart rates these days using a watch, you can look at heart rate as an indication of the intensity of the workload. So if you're walking for about 10 minutes around the neighborhood and your heart rate is 140 and you're feeling the fatigue and you're feeling the chest pain, then you know that you need to dial back down to walk even slower, maybe at 120 or 125 beats per minute. So the heart rate can be very, very helpful to help you to go up or down as you are going through these activities. Now, if heart rate is great, but if you have medications that might impact the heart rate, like beta blockers, then it may lower your heart rate, so it will not reflect truly the intensity of the workload. And therefore, these perceived exertion chart that you can find online, whether it's a scale from 0 to 10 or from 6 to 20, it's probably a better way also to help indicate that workload, the activity, how hard is it for you. So if you feel like I'm doing a chores for that lasts me 20 minutes on laundry here, and my exertion is 11, and I'm feeling good, so you know this is what you can do for 20 minutes. Or vice versa, you know, if you are doing a chore that lasting 30 minutes and you're giving yourself a 17 very hard, and then you know you want to dial back down in a way to taking some break in between that chores of 30 minutes so that you don't get to that rating of 17, 18, or 19. Some of the general guidelines, these are for the post-COVID long haulers, but also for the trainers, exercise physiologists, rehab specialists. Again, is to remind them that they cannot adopt this traditional method of training somebody to improve the aerobic capacity or improve the muscular strength here. The goals, again, the primary goal is to prevent further deconditioning, to maintain the functioning, and make sure that if they have a plan in place is to review with the patients, because if the patients feel lack of energy and is not feeling good, it is important to adjust that program for that day. As opposed to, this is my program, you will get this done for me today, okay? So this is not in the military here, and you're not training for a marathon or 5K, but again, your goal has to be modest, is to prevent deconditioning over time. Certainly, these professionals need to have good counseling skills and knowledge of fear avoidance, and coaching patients to reduce intensity when they feel like they're getting more tired, and definitely coaching them not to overexert themselves, because there's a tendency for anybody to go stronger, to do more if they feel good. But if they do that, they can go over the limit, and now they experience the PEM. So it is a tendency for both as a patient and also for the trainer to push somebody to go longer and harder. So other items, resting, activity, and also nutrition, I think are kind of things that we've gone through already. And resting is important, like I said, is to make sure you find ways to rest. Resting is not just sitting on the couch watching TV or looking at the internet, but you're trying to find ways to maybe relax the body, work on your breathing if you want to, reduce any input that can causing tension in the body, implement other sensory input that make you more relaxed, music, blanket, hot tea, candles, and such. Activity, again, the key is keep the intensity low, but you can increase duration, but keep the intensity low until you feel like you can improve over time. And again, people might get bored with that over time, because I'm not increasing my intensity, I'm doing the same thing here, but trying to find other activities that are fun as well, but the keywords are interspersed with rest periods, okay? Mrs. Schell talked about nutrition already, just breaking down the meals into small frequent meals and staying hydrated. I'm a big opponent of the low carb or no carb diet. And you gotta think about the brain primarily uses glucose to function. So if you're on no carb diet or low carb diet, you're gonna be walking around like a zombie, because the brain needs energy. And so you imagine, put them through this activity routine and they're low in carbohydrate, they won't function well, and it possibly push them over to the PEM as well. But when's the last time you sleep like this baby? Soundly and peacefully. Certainly for adults it's hard. I think I'm not a sleep expert myself, but I think there are some suggestions you can see on the screen in the way to make sure you get a good quality of sleep, and it will help manage the fatigue on a day-to-day basis as well, whether it's avoiding certain beverages, getting a good routine, trying to relax before you go into bed. And the very last slide here is just kind of go over one more time the importance of these expectations for the post-COVID long haulers. expectations has to be low. If you're going over expectations too soon, too fast, again, it will hurt them in the long run. They're going to skip their workouts at the rehab program. So the key is to keep the expectation low. What's realistic is I can do this for 20 minutes. That's it, right? And you can increase duration as you go interspersed with rest periods. Fatigue, they need to understand the fatigue is real and needs managing. So once you have that concept, the attitude of, okay, I need to manage my fatigue. I have to work on it. I have a plan in place. I'm going to take breaks in all these different times of the day, or maybe within the activities. If you have the attitude, it will really help you as a patient in a way to reduce that frustration and anger and be able to manage that over time. It can be taking a year, maybe 4 years or 5 years, but let's hope it will be less than that, right, for these post-COVID long haulers. Support is important. Making sure the family members, friends, neighbors, knowing that you're going through the fatigue on a daily basis, and so they can help you, the patients, to help the patients in a way to understanding that the person needs more rest during any activities. Pacing is important, whether you're doing schoolwork or homework. And if you're caring for family members, making sure you have enough help as well to make adjustments so you can manage the fatigue better as well. And that's all I have here. Any questions for me?
There's one on the chat, and they were asking if you could address the role of vitamin D on the mitigation of the cytokine storm.
Yeah, there's quite a bit of research on vitamin C and D to reduce the inflammation. It requires a very high dose of vitamin C and vitamin D. And Mrs. Schell has talked about just getting enough from your diet. But some of the clinical studies have shown that you have to have a very high level. It's certainly below the toxicity, but 1,000, 2,000 milligrams of vitamin C to see the effects of reducing inflammation. So there are some benefits of those if the person can tolerate that high dosage of vitamins. And I think they're certainly worth looking at along with managing the fatigue and the inflammation.
Right now, we'll take a 5-minute break and then be back we'll be back in 5 minutes.
Go ahead. Okay. Please join me in listening to some of the voices of those nurses living through COVID-19 and the new face of nursing practice. I have COVID, and as a healthcare professional, I know good and well when I should go to the hospital, but I have not gone. Why? Fear. Fear that no one will be able to look after me properly. I had a bad experience with a kidney stone in October. I know how busy the floor nurses are and am afraid of getting into a breathing situation with no one to advocate for me. So I've stayed home. The ethics of refusing to allow families at the bedside of dying elders due to COVID spread risk, and the ethical duty of nursing and NPs to advocate against this practice. Not a BJU grad, but believe against this anti-Christian practice. Agreed. Coworkers and I were talking yesterday about this. Why can't family members sign a waiver assuming the risk involved and entering the room? I have seen so many people die alone. Also, of nursing home patients being denied transport to hospitals, especially those with DNR mostly. Saw many a patient talked into a code change just to deny entrance to the hospital. EMS wouldn't take the patient without their approval. I heard my share of EMT triage and denial transport because patients weren't sick enough for transport to hospitals or were scared into a no transport because they might get COVID. I took it upon myself to have a conversation with one local county EMS director who had a specific squad particularly at fault and had several bad outcomes, and went down a list of specifics with him. He was very receptive. There are ways of meeting people halfway and mitigating risk. I work on a COVID floor and we call families in if their family member is dying. They do not die alone. I also work on a COVID-19 floor and we had the same practice from almost the beginning. Now each COVID-19 patient can have one visitor for the hospital stay. The visitor can stay for up to 2 hours, but better than nothing. Completely agree. And it wasn't just the COVID patients. At one point at our hospital, no visitors were allowed in at all, regardless of COVID or not. And it would crush me. I cried a lot. I want to add, though, that I have strong disagreements with the general no visitors policy for the COVID floor. We have enough PPE now, and support from family is so important. I would agree that as an NP, I deal with elders who get discharged from COVID units, that families and patients come out and so much is lost because discharge paperwork only covers so much. And with no one there, it's tough to piece together sometimes why patients were started on meds. Of course, I'm supposed to know why, and I'm left guessing often, especially if the meds aren't involved in their diagnosis. I think it not only changed nursing at the bedside, but teaching as well. In reference to delivery of care and delivery of nursing education, I'm currently teaching health assessment. COVID has changed the way we teach health assessment. My patients have gone from misinformed when I graduated 10 years ago to less informed to now completely clueless. They don't know they can ask questions. They have no idea what questions to ask. I have to make sure I'm at the bedside with every doctor because I know the patient won't understand what's being said. Every patient is given options and then says, well, what should I do? Or is just expected to be told what they should do. There is no education or choice. They don't even want it. Patients also don't seem to understand that nurses don't make the rules. We are their scapegoat when they don't like the rules. I'm sorry, but the childbirth center is still a COVID floor. We have COVID positive patients and therefore have COVID rules. I don't like them either. But that doesn't mean there is anything I can do for you when you decide to take your frustration out on me. Also, COVID broke me. I'm completely burnt out and ready to get away from the bedside. I'm not sure I can even talk about it. Being a COVID nurse has broken me in ways I did not even know were possible. Fighting so hard for every life and seeing so many of them die anyways. Being the nurse, chaplain, housekeeper, translator, phlebotomist, pharmacist, family, friend, cheerleader, and griever. I still have nightmares about patients who died. I still grieve for people I never knew until I held their hands, prayed for them, and sat with them while they died. It is completely devastating. 100% feel this, every word. A long, long year that will have lingering mental health impacts for years to come. I agree. I have also left my job in ICU, which I loved, and taken a position in outpatient. I can relate to this. I don't talk about it. I hear you about not being sure I can talk about it. It often makes me cry if I do. It feels isolating in a different way than other experiences, and by far is the hardest nursing I have done. The struggle of having to go through the same thing for months, trying so hard, knowing that it won't make any difference in the end. How do you tell the wife of a patient on CRT that no, he's not better? What do you say when she asks, how long till he gets better? When you have yet to see any COVID patient on CRT survive, never mind recover and discharge. When you are so tired of having to tell each family that each shift, and the patients and families who believe it can't possibly be that. It must be something else that is making them sick. The doctors must be wrong. It can't be COVID-19 that has made them this sick. I feel like there is going to be so much fallout in the nursing field from this, especially for bedside nurses. But yeah, I feel like the new face is burnout. Nurses running codes on positive patients while doctors, residents stayed outside not to be exposed makes a lot of us feel expendable. Or waiting around on new admits until the rapid COVID swab is negative. The new face of nursing practice is burnout and PTSD following COVID. The struggle of being emotionally there for patients and their families after caring for COVID patients, and the struggle impossibility of being emotionally available when you are burnt out, overwhelmed, and depressed, hopeless, and having to retrain your brain to care for normal ICU patients versus COVID ICU patients. For example, 12 is a lot of PEEP for a normal ICU patient, but not for a COVID ICU patient. Sedation of 200 fentanyl and 100 Diprovan is a lot for normal ICU patients, but not uncommon for a COVID ICU patient. There are so many ways I feel like COVID has changed nursing, but some things will always be the same. The pain med that starts with a D will still always be the only one that works. The impact of seeing coworkers die, or healthcare workers die from it, and watching people to continue to say it's just a hoax. Or you can do a study on how many nurses are leaving bedside. I hear a lot, me included. Even though I loved bedside, I realized you can get burned out from something that you love. So I'm doing office practice now and working extra shifts and watching my Christian friends argue about it, then getting COVID myself, and watching my mom suffer because I gave it to her also played a role. I left the bedside a year before COVID, so all I have is outpatient perspective. Within our office, we changed the way we screen for appointments. Many appointments transitioned to telehealth, so we were IT support for both physicians and patients. We continue to see an increase in patient anxiety, not wanting to come to the doctor's office, increase in cancer diagnosis, especially recently, and poorly controlled diabetes. A1C numbers that were once controlled were significantly out of range. Working in outpatient pediatrics, the ethics of seeing symptomatic kids in person versus telehealth to lessen exposure to staff and providers. We did so many parking lot exams in the middle of a northern winter to avoid bringing a potential positive patient or parent into our office. Huge increases in adolescent mental health diagnoses, including eating disorders. I heard the head of our medical school say he expects being a child during COVID-19 will likely become an ACEs checkbox. I can identify with all those who are burnt out from COVID. After watching the last year in the ED, we moved, and I'm glad for the break. Watching someone struggling to breathe and being taught about intubation with the possibility of never coming off still sticks with me. Hearing that a code is coming in, but because that person could have COVID and we're not going to work it, floored me. The fear of COVID affecting our decision-making so much so that families need special approval to see their loved one, as in they must be dying, changed me. Hearing that someone you worked on at the end of your shift died later that night makes one feel like a failure. This fear of COVID has pushed unthinkable policies in place that I never thought possible. Having new nurses start at the beginning of the year and seeing what 1 year has done to them is so disheartening. It's not the rewarding field it used to be. Either I can't please management by keeping every single policy, or I fail my patient. On the flip side, my teammates are some of the hardest working nurses I've ever seen. Seeing it all and still coming back to work is a resiliency I've never seen before. It made our team so much closer to go through such difficult events together. We're all burnt out, but maybe it's just waking people up to make mental and emotional health a priority more than before. I believe we're going to see some real PTSD from this, but I have to trust that God is still in control. Agree. I think the mental health of nurses working or having worked during the pandemic will be a hurdle those nurses will face for years to come. Working in OB, I don't work in a high-risk area. Still, there were stressors related to COVID. First, a few positives. Less visitors in maternity wasn't the worst thing. Many parents actually said it was nice to be able to just enjoy those precious first days with the baby by themselves. Also, we saw a huge increase in breastfeeding rates because visitors are a huge hindrance to breastfeeding. We always allowed one support person, and extenuating circumstances we allowed two. On the nursing side, pandemic staffing. Floating OB nurses to regular floors, even to task, is too much. We are outside our comfort zone. Some of us haven't taken care of an adult patient besides postpartum moms since nursing school. A long time. I don't just know what tech duties are on each floor. Our techs are OB techs and scrub for C-sections, set up for deliveries, take vital signs, give baby baths, etc. While many floors were grateful for whatever help we provided, some nurses units treat OB nurses as lesser because we don't know what they know. Our skills are hyper-specialized, and we have never expected a float coming to us to know how to do what we do. Most of our staff is concerned that admin will think floating worked for COVID times and it won't go away. It will become the new way to short staff units and not need to hire more staff. We lost many nurses related to floating. Overall, I fear that we created a nursing shortage that is not recoverable. The amount of burnout in COVID units, fear of floating, new grads being thrown to the wolves, it's truly appalling. The Year of the Nurse highlighted not only the tenacity of nurses, but the travesty of staffing. Well, as a new nurse going to work right when the pandemic started, I'm not sure I have a good idea of how COVID has changed nursing, but I can see how it is now. And honestly, sometimes I'm not sure why I signed up for this. Staffing ratios were atrocious during the worst of COVID. And despite my floor being the med-surg COVID floor, I was still pulled 1 out of 3 shifts a week to float to the PCU COVID floor. As a med-surg nurse not trained in certain PCU practices, floating there always made me super anxious. There were many times when I had patients with drips I could not titrate because I wasn't a PCU nurse, and I had to seek help from the already drowning PCU nurses. And now it seems the floating isn't going away. I feel like a float nurse since I work away from my own floor so much, without float compensation, I might add. Additionally, I've seen way too many pulmonologists do doorway evaluations on patients because they didn't want to enter a COVID positive room. All the while, we nurses have been going into those rooms every day, multiple times a day. The actual lung doctors weren't going in to assess their own patients while the virus wreaked havoc on their lungs. And that really made me upset for the patients' sakes. I hear nurses tell me all the time that since I've entered during the pandemic, when nursing returns to normal, it will be so easy. But so far, I haven't seen anything get easier. I've only seen a wave of nurses leave the bedside, switch floors to escape COVID floors, or leave the field entirely. It's not getting easier, and I don't think it was ever easy to begin with. Despite all the negatives that have come with starting my career in a pandemic, and despite all the patients I haven't seen get better, I still rejoice over the patients I have seen recover from COVID. The joy the patients have at beating such a disabling disease has me thanking God and encourages me to keep going back to help those who need it most. The impact of patients in long-term care not being able to see family. Also, my friend's husband is homebound and she can't get anyone to give him the vaccine or to give it to her to administer, even though she's a nurse practitioner. I feel bad for brand new nurses on our unit. Their training has been secondary to patient care with poor staffing related to COVID. Many quit. I work pulmonology thoracic IMCU, and I've spent most of my time in the COVID and non-COVID ICU as an assist RN. I second what so many have said about not being able to talk about what I've seen and experienced. I feel like my heart has been seared, burned again and again, until I start not to feel the pain of empathy and compassion anymore, and the patients turn into bodies in beds. Then I panic at not feeling anything and force myself open to my patients and the pain again. It's a punishing cycle without end in sight. The new face of nursing is without a doubt PTSD and burnout. I've seen experienced and compassionate nurses leave the bedside in droves. Newer nurses with little or no experience of non-COVID nursing are being burned out and leaving the field altogether. I fear the nursing shortage will only get worse without retention of both current and new nurses, which will drive staffing changes that will cause even more burnout. The new norm of nursing is basically working 4 days a week because people calling out sick and the on-call nurse getting called in. The challenges of dealing with patient family are increasing because of hospital regulations. For instance, the patient is wanting to have a family meeting with palliative care, but because of COVID regulations, only 2 family members are allowed in the room for family meetings. Well, what happens when the wife and the 3 children all want to be in on the meeting? The nurses on my floor say it's nice that we don't have to have family members on the floor all the time. But I think some of our patients would get better faster and stay more oriented if their family was there. On a personal level, it's been a struggle to know how much to interact with people outside the hospital. So many people react in so many different ways when I tell them that I often get exposed to COVID at work. How much should I expose outside people to COVID? How much should I spend time with people outside of the hospital because of potentially sharing germs with my patients? Being told to cluster care, limit exposure, and conserve PPE sounds entirely logical until you're caring for an 80-year-old woman who hasn't seen her family for 3 weeks and is begging you tearfully to please stay and talk to me for a few more minutes. This disease is scary. Some of these people are incredibly sick. Caring for them is physically demanding and mentally exhausting. My heart breaks for their isolation, even as my brain begs people to please stay home. Today, I'm thankful for a day off, for blue skies and sunshine, for my family, for the outpouring of love from the community for me and my work family as we care for our patients, for the love and prayers of friends and family. I know I can't explain everything, but I am so thankful that you care. This has been such a beautiful and hard year for nursing, even for someone who has been at it for over 30 years. COVID has changed us all. Here are some of my biggest lessons from the year. Number one, nurses are creative and resilient. When we were told there wasn't enough PPE, we found creative ways to make do. When we were told to limit visitors, we used phones and iPads to keep families connected to patients. When we first started this journey, we stayed in hotels away from our loved ones to protect them. When we were given new protocols several times a day, we accommodated and adapted our practice. Number two, we have seen horrible things that have changed us forever. Privacy went away for our patients. In my ED, we had to take down the curtains between patients to accommodate more stretchers, making it nearly impossible to preserve human dignity. In order to code a patient, the bed was pulled out into the walkway so that we could get to both sides of the patient. I remember looking across the room during a code and seeing two of my patients holding hands over the rails of their stretchers, watching us do chest compressions. I will not forget the terrified looks on their faces. Our ED became a holding area for people waiting weeks for an ICU bed. So our waiting rooms, lobbies, gift shops, and hallways were converted into ED treatment rooms. When the number of dead bodies far exceeded our morgue capacity, we brought in refrigerated trailers to hold them until the funeral homes could come get them. Number three, we can make do with less, but we love our equipment and gadgets. It's very hard to be part of discussions to determine which patients are most likely to survive and therefore more worthy of equipment such as ventilators and IV pumps. I never imagined having to decide which of my vasopressors had to be run without an IV pump. And I will not take a fully stocked supply room for granted ever again. Number four, bedside nurses are amazing. I am proud to be a longtime bedside nurse, to be the one to spend the most time directly caring for people in the most difficult times of their lives. I also know that I am traumatized by the things that I have seen and done, and I'm forever changed by this last year. Two of my patients died yesterday. The first was a middle-aged man. He was a delightful person to know. He was on a couple liters of oxygen on our COVID med surge unit for 2 weeks. A kind, joyful man who wasn't too sick until he was. Last Tuesday, I was charged when he acutely decompensated. As we were rushing him to ICU, he looked at me and said, "I'm not going to make it. I've been putting my affairs in order." A few hours later, I was holding his hand, praying for him while we prepared to intubate him. He was struggling to breathe, but he made eye contact with each of us and said, "Thank you for taking care of me. It's going to be okay." That was the last time he was awake. He died yesterday. The other patient was an 88-year-old woman with advanced dementia. She was never really conversant. We moved her to ICU last week too. She had a massive saddle pulmonary embolism on top of COVID. We tried everything. Nothing we did made a difference. She died yesterday. Her family chose not to come. She died alone as her nurse sat with her and held her hand. We are the nurses, friends, chaplains, and families. We see them improve slowly or decline quickly. It's been a hard week. So many tears this week, exhausted, discouraged, grieving, clinging to the hope that God can use even my shards of brokenness to make a difference in the lives of the people he brings across my path every day. Begging him every moment for the grace to serve others with joy, even as my heart cries out for relief. Y'all, I'm done. I deal with the nasty uncertainties of coronavirus every single day that I work. I see the sickest of the sick. Caring for these patients is physically, mentally, emotionally, and spiritually exhausting. My coworkers and I have been devastated and broken by the causality of these diseases. Every day, I pray for a cure, for something that will be a light at the end of the tunnel. Every day, I pray for my patients, their families, my coworkers, the nurses and physicians who are inundated with the total care these patients require. I just do not have time or energy to debate natural, artificial source, medications, masks, vaccines, supplements, the political fallout, various conspiracy theories, shutdowns or reopening, etc. In our current information age, anyone can find support for any idea. Something that I learned and will continue to learn is that there are so many facets to this thing called knowledge. There's also understanding, wisdom, and discernment. Please pray for me. Pray for all the healthcare workers you know. Pray for us. Know that we want this to be over more than you can ever understand. Know that we are doing our absolute best with the knowledge we have. Know that we rejoice with survivors and cry for every patient who dies. Pray for us. Love us. Forgive us if we seem short-tempered or distracted at times. Try to understand if we suddenly start crying when something reminds us of someone we have recently lost. We can't be unbiased. We want to understand, but we can't examine this from a strictly academic angle. We can't step back. It's too close. We are too close. It's been a challenging 6 months as we transitioned into a new specialty, a COVID ICU and medical surgical hospital. I've been challenged and stretched in ways I never thought possible. I've wept over patients I hated to lose, and I've smiled through a sheen of tears as patients went home after long months of illness. I've met and worked with so many fantastic nurses, respiratory therapists, and doctors. I've learned and grown so much as a nurse and as a person. And still, I am prompted to say with Patch Adams, you treat a disease, you win, you lose. You treat a person, I guarantee you, you'll win, no matter what the outcome. Tonight, I sat with a man for 2 hours while he died. His wife was also sick, and his family was unable to travel to be with him in his final hours. This was the third night I took care of him this week. The first night he was on Vapotherm, 40 liters per 100%. He decided if he turned over in bed, but he was alert. He wanted to talk but couldn't say much. He smiled. He thanked us for all our care for him. He told us he was praying for us nurses as we cared for so many sick people. The second night he was on even more oxygen. He told the doctors that he didn't want to be on a ventilator. They told them there was nothing more they could do. He said it was okay. He was ready to see his Savior. He said he was praying for us. The third night, he was decompensating rapidly. He was dying. He couldn't communicate verbally, only with his eyes. He wasn't afraid, but he couldn't breathe. The doctors, respiratory therapists, and nurses did as much as we could to make him more comfortable. But the end was near. When you've seen as much death as I have, you recognize it clearly. I got some medicine and a chair. I put on my isolation gown, my N95 and surgical mask, my face shield and gloves. I prayed for strength and for God to use me to comfort this dying man. And then I went into his room and sat with him. I gave him medicine to ease his breathing. I prayed for him, sang hymns, quoted scripture, Psalm 23. God walked with him through the shadow of death. His face was peaceful. He gripped my hand, and then he died. I cried. I talked to his family. I cried again. Another nurse and I bathed him and prepared his body. The final gift I can give this man and his family. And then, in never-ending routine, I put on my isolation gear and went in to care for my next patient.
All right, thank you, Valerie. We appreciate those stories of what people are dealing with every day in the real world. We certainly need to keep that in mind as we're talking about the science of this, but how it impacts real people. So I want to thank those of you who have stayed with us. I am Dr. Amy Hicks. I'm the chair of the Division of Health Sciences here at Bob Jones University in the School of Health Professions. And my talk is a little bit, it's along some themes that we've heard today. So some themes of who's impacted most by this, what are we expecting, what are some of the significant side effects, but it's really looking at what do we do from here on out? Where are we now and where are we going? And unfortunately, there's less of an evidence base to this because we are walking to some degree into some uncharted territories. Though if we learn lessons from previous pandemics, previous disasters, there's much we can learn. But the title of my talk, of course, then is Recovery, Rebuilding Communities and Families. And first of all, let's have a little bit of background into the way we have seen disease change over the past 150 years. So for all of history, basically, mankind has died of infectious diseases. Mankind died of waterborne diseases, sanitation diseases, measles, malaria, and so there was a short life expectancy. But since the 1900s, as countries began to develop, they moved away from a high burden of those infectious diseases and moved into a decrease in infectious diseases because of things like vaccines, as we heard Dr. Kelly say first off this morning. And instead, we see this rise in non-communicable diseases, diseases that are related to behavior, that are such as diabetes, hypertension, cardiovascular disease, stroke. And so Dr. Kadio made excellent point about the fact that countries where we have seen this shift, we were spectacularly unprepared for meeting the needs of a new pandemic, of infectious disease suddenly being imposed on us very quickly. I think our expectations were too low. We did not foresee, many of us, the degree of the scope of magnitude that this would have. And so we've seen this shift in disease known as the epidemiological transition. And since the beginning of this century, of the 21st century, we're starting to see another shift. So some of us here at the Center for Community and Global Health have talked about whether or not we may be at the verge of a second epidemiological transition. And so the data that I'm showing here is from the global burden of disease, which we're comparing 1990 with 2015. And this is looking at dailies. So the global burden of disease, whether it be from death or disability for any given category of disease. And in 1990, you see that the majority of our disease burden was from things like circulatory issues, heart disease, strokes, cancer and tumors also were a major part of our disease burden. But as our treatment, our early diagnosis, our prevention have improved, we've improved the ability, we have reduced that disease burden. So both circulatory diseases and cancer have decreased in the health burden. But one very striking increase is occurring. Mental and behavioral disorders have gone to being the #1 leading cause of disability and deaths in the US. So if we count both disability and deaths, we see mental health and behavioral disorders making a huge impact in the population. And so this has been magnified by the current pandemic. We're going to look at some of the ways in which this has been, it's under a microscope, and we have seen this magnification of anxiety and depressive disorders. So the first bar here is looking at data collected by the National Health Services from January to June 2019, before the pandemic. And we saw that at that point, about 11% of adults reported having symptoms of anxiety and depression. However, when that same data was looked at for January of 2021, 41% of adults reported symptoms of anxiety and depression. And so we're looking at what's potentially the second wave of the pandemic. We've seen the infectious disease, we see the deaths that have been caused by infectious disease, but now we're seeing this rise in mental health disorders, in despair, in depression and anxiety. And along with that, we are seeing an increase in what's known as the deaths of despair. So if we look at the deaths of despair, it's been made worse in 2020, but you can see this graph actually only goes up to about 2015. And the deaths of despair did not fall on a blank slate. There were already many issues in the US that were causing an increase in this. So if you look at the deaths of despair, this is a category that includes 3 main types of deaths. So suicides would be considered one of the categories of deaths of despair, alcohol related, and then drugs, substance abuse. And so if we look at this over time from sorry about that, let me go back. From 1900 to 2020, almost 2020, you notice that right around 2000, there started to become this exponential rise in deaths by suicide, deaths by alcohol, but particularly driven by the opioid epidemic, deaths by drug overdose. And so there's still a lot of debate about what exactly is fueling this, what exactly is fueling the deaths of despair. And so there's multiple points of view, there's different schools of thought on this, but some of those include societal structures. So we have seen an increase in the breakdown of societal fabric, more division, more discord. We have seen income inequality vastly exacerbated in these last few years, so that we have the rich, we also have this great divide, and areas of income inequality are correlating with areas of deaths of despair. In addition, we see economic. So at any given time, when there's a downturn in the economy, deaths of despair go up. So you can see that you see this giant peak in about 1907. So in 1907 there was a Wall Street, a major fallout of Wall Street where it fell by about 50%. Right after that, deaths of despair, particularly suicide and alcohol, peaked greatly. After that, you see again another jump by suicide around the time of the next Wall Street catastrophe, which was the Great Depression. And then the third one is a spiritual and mental focus. So do spiritual and mental issues also cause deaths of despair? And so we see that with decrease in social cohesion, an increase in social media, which exacerbates depression as well. And the 60s are a good example. We also see a breakdown of societal norms of social cohesion, leading to another jump in deaths of despair. So this has been a pattern going on in the US, certainly much worse since 2000, but the COVID pandemic has really caused that to go into overdrive. And not just in the US, but we're seeing research is showing in other countries such as Japan, where there was a large spike in suicides. And then this rush to think, what do we do about it? How do we help to build resilience in our populations, in our communities, and really in our individuals and families? So working in public health, then, my perspective is that we look at, first of all, who's most at risk. We have to understand who's at risk, who are our vulnerable groups, who are the populations that we should be most concerned about. And then from that, what are the structural issues? What are the concerns that we need to see for each group? And we'll see that those stressors are different for each group. And then based on that, when we know the factors that are involved, so what do we do about it? What are the evidence-based programs that we can put in place? And that's really where we lack. That's what research is going to have to improve and going to have to show. We currently don't have a lot of good evidence-based research showing the building of community resilience. So let's look at who is most at risk. So first of all, if we look at the demographics of those who report anxiety and depression, we see this, the data that I'm going to show you is collected by the US Census Bureau. They instituted what's called a household pulse survey, so that any given time emails are sent out to random houses, and people fill out these surveys and just get kind of a real-time snapshot of what's going on with the respondents. And so of the people who responded to this survey, they found that women, and particularly mothers, women with children under the age of 18, were more likely to report anxiety and depression than were men who also had children under the age of 18. So reasons reported for that included burnout from their jobs, worry about their children, worry about their children's education, a larger share of child-rearing responsibilities. And so these factors tended to put women and mothers more at risk than their male counterparts. Additionally, we look at another demographic and we start pulling this apart by ages. We see that younger adults, particularly those ages 18 to 24, are significantly more likely to struggle with mental health issues than our older adults. And at each level of those age brackets, that percentage goes down. So why are they struggling? And again, there's multiple reasons, and it's going to depend on individual characteristics. But in general, they reported things like university closures, a fear of the job market as they're moving out into the next phase of their life, as well as the fact that resilience is a developed skill. The ability to bounce back from trauma, from difficult situations, is something that's learned, not necessarily something that's innate. And so older adults have had experiences that have allowed them to learn this. And so we're seeing during the COVID crisis that younger adults and even adolescents are at risk for things like suicide and substance abuse. This data is from the CDC. So this was reported in Morbidity Mortality Weekly Report. And this is looking at pediatric ER visits over the course from January to October. For in the dark line, we see 2019 as our baseline comparison. And then the broken line is 2020. So looking at the ER visits for pediatrics for those under 17, but specifically at the proportion of those visits that are related to mental health issues. And so what we see, we saw closures and school closures happen right around this time, right around week maybe 10 through 12. And then shortly after that, there was this large jump in mental health issues for adolescents and for children. So some of the factors that have been used to explain that are stress of parents. So children taking on the stress of parents, but also as well, there school closures, a lack of services. We've already heard today that schools are not just a part of education, but schools are a part of overall community service. So many children access food, healthy food. Many children access counseling, speech language therapy, other types of therapy, other types of support services, and suddenly those were not there. There was also an increase in child abuse because of families being under so much pressure, and children had nowhere to go to get away from that. They were spending more time with their abusers. And so because of this, we have seen and likely will continue to see lasting effects, long-term effects of mental health issues in children. That's just something we need to be very aware of. So the measures that we have taken also impact people's mental health. So Dr. Kadio mentioned earlier that really in the West, much of the focus on disease transmission revolved around the idea of isolation. Some states in the US were much more vigorous about isolation, and some states were much more voluntary about isolation, but everyone experienced it to some degree. And so if we look at these groups, these two groups, and the US Census divided them by those who sheltered in place and those who did not shelter in place, we see a couple different things. So we're looking at, in the light blue, a minor negative impact on mental health, and then in the dark blue, a major negative impact on health. And so both groups expressed about the same levels of minor negative impact on health. But what was important is that those who were isolated, so sheltering in place is kind of a nicer euphemism for saying isolation. Those who were isolated reported a significantly higher major impact on their mental health. And this makes sense, but the measures that were used to protect and that were necessary to a level also have put people at greater risk of long-term effects of mental health issues. Another big component of partially isolation, shutdowns, we saw a large number of jobs lost in the US. So in 2020, about over 2 million total jobs were lost. So far, about 9 million of those jobs have been regained. But if we look at the jobs that were lost, we see a high preponderance of those jobs being included in low income, low paying jobs. So for instance, restaurant workers, manufacturing, retail, construction, those are lower paying jobs, but those were where we lost a lot of the sector. And so this also contributes to a greater income inequality, to greater stress on families that already had more stress anyway. So if we look at the mental health impact of that, for those who lost their job, more than half, 54%, reported adverse effects on mental health, compared to about 40% of those who had not lost a job or their income. So this downturn in the economy, just like we saw in 1907, 1929, 2008, and the other recessions, these downturns in the economy coincide and cause large upticks in mental health issues. And then as we see people losing their job, we see more people falling below the poverty line, more people falling into lower income brackets, and that has a major impact as well on mental health. So families that make less than 40,000 were much, much more likely to report major negative impacts on their mental health versus families in higher income brackets, 90,000 a year, were half as likely to report those same major impacts on mental health. So this is who we need to see. If we're concerned about public health, we're concerned about equity, we're concerned about vulnerable groups, these are the groups we really need to focus on. We need to focus on low income, we need to focus on mothers with children, we need to focus on young adults and children, and develop evidence-based resources and evidence-based interventions then that are able to target these particular groups and make a big difference. And then lastly, I couldn't say this any better than Valerie already did. She mentioned the many stressors on essential workers, which include healthcare workers. And so if we look at essential workers versus non-essential workers, those who had to be in the front lines, we see symptoms of anxiety or depression at 42% in essential workers versus 30% in non-essential. Substance abuse rose sharply among essential workers, which includes both drugs or alcohol. That rose sharply by 25% of essential workers compared to 11% of non-essential workers. And then lastly, seriously considering suicide. So the risk factors for those deaths of despair that we looked at are much higher among those who had to go to work or who could not shelter. And we saw in our last talk why. What were the factors behind that? But so it was also factors of burnout, factors of fearing that you were bringing something home to your family member, fearing for your own perception of risk as well. So what do we do about it? Well, that's where I think the public health world, the science community, the healthcare community, social workers, economists, many different voices are going to have to speak into this. But if we're talking about the need to build resilience, and I'm borrowing these figures in the next couple pages from Harvard University in a publication that they put out from the Center on the Developing Child, talk about the ability of a person to bounce back from severe trauma, from difficult life circumstances, is really dependent on multiple things. So we have the person's own genetic makeup that's going to play a part. We have the person's individual characteristics, their age, their sex, their propensity to depression already, or their propensity to optimism. So there's individual characteristics that impact whether or not someone has an easier time toward resilience, but there are also that interacts with life's circumstances. So the life circumstances may be negative. So they may be difficult things like a job loss, a loss of a person, a loved one from COVID. Many of us know somebody who's died from COVID. That's a traumatic life experience. And the closer that person was, the more difficult it is to bounce back from mental health problems. Physical distancing. So in the beginning of this, we all saw everywhere you go, it says we're all in this together. After a while, that message became very grating because you felt like we're not in this together. I haven't seen anybody in months as schools closed down, churches closed down. And so physical distancing, closed schools, those things cause a propensity toward negative outcomes. But those can be balanced with positive aspects, such as high quality childcare, access to services that the family needs, stable housing. The more someone is worried about the stability of their house, the worse their health outcome is going to be. So how do we change it? Well, first of all, reducing sources of stress. And this is going to depend on your group, your individual. Who is it that you're trying to help? What are their sources of stress? But it can mean many things. For everyone, it means clear information. So one of the sources of stress at the beginning of this pandemic was mixed messages, unclear, constantly changing information, which caused a lot of extra stress to people and ultimately caused many people to fall into two camps. I don't believe it, this is all political, or a great fear, an excessive fear. And so public health has to have good, clear messages. One of the issues, of course, of living through a pandemic is that we're learning as we go along. And so to some degree, messages do have to change, but that public trust has to be built and it has to be maintained. Increasing access to community services during underemployment or unemployment, removing some of those stresses of food and rent and unemployment benefits, and then ensuring access to education. So I think by now, probably most of us know that the #1 predictor of a person's health outcome is their education. Particularly in the US and developed countries, the #1 socioeconomic factor of how long you will live, what you will die from, how sick you will be, is your education. 3 million children in the US have been absent from school, just not attending in this past year. Those children were the ones that lacked access to stable internet, lacked technology, lacked a person who was able to tutor, who was able to help them maintain their schedule. And so we're going to see this divide. There was already a divide. COVID is magnifying that. So groups like the American Academy of Pediatrics, UNICEF, so international groups, national groups have all advocated strongly that schools have to be in person. Children need to be back. And if that doesn't happen, we'll continue to see a greater divide. Secondly, we can increase positive outcomes by supporting responsive relationships. So again, we've identified those at highest risk, maintaining and encouraging connections. So in whatever way that is, we as a society have to look out for those that are at the highest risk and then maintain those connections. Extending benefits. So the government has done that as well by extending some unemployment benefits, encouraging job flexibility, ways to help families and individuals overcome the difficulties they have by improving access to help. And then lastly, whenever you're on a teeter-totter or a seesaw, when you're little and you're on a seesaw, you got 2 kids on either side, right? And the heavier kid is always going to pull that seesaw down. And so it depends on the positive and the negative, what weight we have on either side of that. But another way to change this balance and improve resilience is just to move the fulcrum. And the way that we move the fulcrum is by strengthening core life skills. So setting reasonable expectations is a big life skill that we have to encourage. When last March, when everything closed down, I know I kind of thought, well, we'll all go into quarantine till May. We'll come out. This won't have been that big of a deal. Vastly underestimated what my expectations should have been. And research has shown that setting reasonable expectations improves mental health. So in the London bombings during World War II, when London was being continually bombed, and many families packed up their children, put a sticker on them, stuck them on a train and shipped them off into the countryside. And what they found was that those children had very poor mental health outcomes because of that, the isolation of that. But families did that because they were expecting this to be a very short-term problem. But as those London bombings played out and they realized, no, we're going to have to deal with this for a while, they brought the children back. And even though there were still bombings going, they brought the children back. And so what they found was that the children who came back did better mentally, even in the middle of the bombings, than they did when they had been isolated, when they were away from their families. And so expectations about, okay, we're going to handle this together. We have support. That's very important for improving mental health. Educate on a healthy lifestyle. I won't go into that because we've already had 2 sessions on that, and very important. Decreasing the stigma of counseling. Many people are afraid to admit that they need help, that they have mental health problems, because they view it as a weakness, a sin, whatever it is that's holding them back. But by decreasing and having transparent conversations to decrease the stigma, we help people move out of the mental disabilities, mental health issues much more quickly. Expand coverage of healthcare. That's both preventative healthcare, but it's also increasing mental health care. The US has long been very low on mental health resources, and we're seeing that much more critically in the 21st century and then now. People don't have access they need. And some of that then will be to extend and make telehealth more available, particularly with mental health. And so the Congress is already doing that. They passed 2 bills in 2020. So in March of 2020, let me go back. In March of 2020, they passed the first bill, the Consolidated Appropriations Act, which increased funding for mental health and substance abuse treatment, and also required insurance to pay more, regulated what insurance had to pay for mental health services. And then the CARES Act as well, which further increased and then expanded telehealth options. So reduced regulations on telehealth and expanded the opportunities for people to access it, both by government funding and private insurance. So the thing that makes this more difficult, we saw toward the beginning of my second slide, we saw that we have done a great job on hypertension to some degree. We have been successful in reducing cardiovascular dailies and cancer, but we have not been successful at mental health. And mental health is so much more complex. And where we tend to get it wrong is where we tend to think of people as in one light. So we may think of them only as their biology. We may think of them only as their spirit. But in fact, we are a complex interplay between our physical needs, our psychosocial needs, and our spiritual needs. And each one of these impacts each other. So we know that chronic sickness, and we know that COVID long hauling also impacts mental, it impacts spiritual wellness. And so we need to look at a person, at the whole person, and design interventions around each of these factors. And so I just want to close my talk with talking about the need for us to remember to encourage one another spiritually as well. So there we go. So Isaiah 35:3-4 says, strengthen the weak hands and make firm the feeble knees. And I like this verse because we are definitely in the middle of a pandemic of weak hands and feeble knees. A lot of people who are really struggling. Say to those who have an anxious heart, be strong, fear not. Behold, your God will come with a vengeance, with the recompense of God, he will come and save you. And so it helps as we remind people that we are not random victims of this. There is a purpose, that there is a greater good that can come out of this, that we can look forward to something good, not only something bad. And we increase and encourage people spiritually, mentally, physically, and meet in all of those categories and help people to build resilience and bounce back from this. Okay, I think we have a few minutes, Caleb, for questions. We don't, there are no questions? Okay, all right. Okay, well, for those of you who are joining us on Zoom, we thank you for coming. We appreciate any feedback. We will get back with you with questions that you may have. And I will bring Dr. Kadio back up to close us out.
Thank you very much, Dr. Hicks, and thank you very much to all those who join us through the Zoom platform, and thank you to all our presenters, all our students, and everyone here. I've been really pleased by the quality of the presentations today, and it's amazing the resources that we have here at Bob Jones University and at the Center for Community and Global Health. I would like to finish by saying that there is a study that will be done based on all the research that you have heard about today. It's called the Quality of Life of COVID-19 Survivors, the QualiCore study. It's going to be in line of what we have heard today using the model that we have seen, because here at the center, our approach is that any health issue has those three components that we just saw: a physical component, an emotional component, and a spiritual component. So using that model as a framework of intervention, we have designed a study called the QualiCore study, and we'll be focusing, and as just we saw, we'll be focusing on vulnerable populations here in Greenville, South Carolina. And it will be a study about rehabilitation. We have heard about fatigue. We have heard about all those symptoms. So it will be, that study will be, we'll use a design, what we call a pre and post, pre-test and post-test design, which is, are going to evaluate the people at the entry level of the study, and then identify some of the factors that we have discussed here: fatigue, all the symptoms, the long hauling symptoms. And then they will be going through a rehab process here with the Human Performance Lab, with all the rehabilitation, nutritional, mental health. We are going to bring the entire arsenal of intervention and apply it to that group of population. And then after 6 months of the intervention, we'll stop and evaluate and report. And so based on those findings, we'll then move internationally and more globally and see how we can use our finding to help people suffering with long-term COVID-19. And at this point, I would like Dr. Benge, if you have a word to say. Again, thank you, everyone. And here's Dr. Benge.
So Dr. Kadio summarized it very well. So there's been 3 aspects of the QualiCore study, which would be the cognitive brain fog, addressing that, the exercise and fatigue, rehabilitating the body, and really getting to the nutrition and mental health needs of the individuals. So we thank you for joining us today. We look forward to answering any questions you have, and hopefully, Lord willing, sharing our results of this QualiCore study with you down the road. Have a good day.